Well, good morning, everybody. I'm Liam Donaldson, the Chair of the Integrated Care Board for the North East and North Cumbria, welcoming everybody to our board meeting being held in public on the 29th of July 2025. And I'd like to welcome members of the board, but also members of the public in the room and our growing online audience. And we're live streaming this, of course. So we have apologies just from one person, who's Jacqueline Myers, our Chief Strategy Officer, and deputising for Jacqueline is Mark Hopkinson, Director of System Resilience. Declarations of interest are in a register, and we just need to note that those apply in a number of our agenda items coming up: the County Durham and Darlington NHS Foundation Trust Breath Services, item 13, and the Intensive and Assertive Community Mental Health Care Action Plan update, that's item 16. And all members with conflicts can remain in the meeting and take part in the discussion, such as the nature of their conflict. Could I confirm with our Board Secretary that we're quorate?
Yes.
Thank you. And turning to the record of the meetings held on the 3rd of June 2025 and the 16th of June 2025, are they an accurate record of what happened? Thank you very much. So we'll approve those. And then we have an action log which reports on progress with matters that were arising from that meeting. Are there any questions or points anyone wants to raise on the action log? Thank you. And then, so that we have a measure of the length of our agenda overall, does anyone have any items of other business that they would like to see added to the agenda? No, thank you. So we turn now to our Chief Executive, Sam Allen, for her regular Chief Executive's report, item 8 on the agenda.
Thank you very much, Chair. I've got quite a long report today. In part, there's been a lot going on, including the publication of the 10-year plan for health for England, which was a much anticipated moment for us all in terms of the plan, and sets out a really clear mandate for change. I think the plan does reflect the urgency around the case for change, and as an NHS needing to adapt to the changing needs of the communities that we serve, and absolutely support the emphasis within the plan on the development of neighbourhood health care. And essentially what this is about locating health services in a very joined up way at the heart of communities. And we do already across the North East, North Cumbria, have many examples of this. And so I don't think we're starting from scratch on this, and we've definitely got more than foundations to build upon here. And with regard to the implementation of the 10-year plan, the very first aspect of this is that focus on neighbourhood health, and we have currently been invited to submit proposals to join a national implementation programme for neighbourhood health, and Levi, our Chief Delivery Officer, is leading that particular work across the system, and working closely with our partners in local authorities and combined authorities, as well as all of our NHS organisations. But neighbourhood health isn't simply about the local NHS delivering everything. It's about how we work in partnership and join up health care around individuals. So the relationships and the partnerships are absolutely vital to support that. Just to say, in terms of the 10-year plan, it didn't address issues around social care. Colleagues will know that the Casey Commission is underway. Just to share that I have spoken with the Casey Commission as the early part of their phase of work, and I've invited the Casey Commission to come and visit the region and see the very good examples of integration that we have across the region and where this works, but also to provide opportunities for us in the North East, North Cumbria to contribute also into that important piece of work. Another really critical report was also published this just following the publication of the 10-year plan, and that was the DASH review, which was Penny Dash's independent report on patient safety across the health and care landscape. And when we talk about safety, particularly through this report, it's very much through the lens of both safety, effectiveness, and also patient experience. And Penny Dash made a number of recommendations and reached conclusions in her report, particularly around needing to streamline and simplify various functions. And this also led to the recommendations as they relate to the Health Watch, the Health and Safety Investigation Branch, National Guardian's Office, and also the Care Quality Commission. And some of these recommendations in this report will require new legislation, but the aim is to simplify the landscape. At our last meeting, we did touch on the announcement that had been made with regard to Health Watch, and I do want to really emphasise our very good working relationship with our 13 Health Watches, and Christopher, as a member of our board who represents Health Watch, we absolutely intend to continue working very closely with you until it is clear on what this sort of transition phase looks like. And I think we've had a very good model here in the North East and North Cumbria that's worked well for us as a commissioner, but also for that voice and that representation, as indeed we have the community and voluntary sector as well. So I think with the 10-year health plan, whilst it will require us to pivot in some areas, to refocus in others, actually it's about building on the solid foundations that we've got here in the North East and North Cumbria. One aspect of my report that I provide an update on is our own transition to strategic commissioning. Members of the board will recall that NHS England published the Model ICB blueprint, and over the last couple of months we've continued to develop our proposals to implement this, which will result in the organisation costing lower than £32 million. So that's the cost we've got to take out of the organisation, and inevitably there will be redundancies as a result of this. You'll see in my report that we are ready now to consult with our staff on our proposals to achieve the new operating model within the operating costs that we've been set by NHS England, but we're unable to proceed at this point in time because it's not yet clear how the redundancy costs will be funded. We'll continue to keep the board up to speed with that. I am concerned about the impact that is having on our staff in terms of their well-being, but also morale, what is also a busy time for us as we seek to now implement the 10-year plan. So I do hope that we are able to find resolution on this in the very near future, and it has been placed on our risk register as a significant risk, particularly given the impact on staff. Just to touch on one thing in terms of the money and our financial position, we're obviously keeping a very tight reins on the money, which this year is our most challenging year financially if we've set out at every stage. At month 2, we are slightly ahead of plan, and our Chief Finance Officer will cover this in the finance report. But I just want to say, from a system-wide perspective, we know that we've got a high level of risk towards sort of quarter 3 and quarter 4 of the year, particularly in delivering efficiencies. And through our System Recovery Board that I co-chair with a Foundation Trust Chief Executive, we are providing a monthly update to all of our NHS Trust boards across the system, as well as the ICB chair, Sir Liam, on where we are against plan, but also where we are in terms of forecasting and the risk associated with it. We will be bringing together a number of colleagues in the month of September to review where we are heading into the autumn and any further actions or steps that we need to take to mitigate the risk in the final part of the year, which I do think is significant, particularly if we are to stay on plan. And obviously NHS England have made it very clear it is the requirement of the whole system to deliver on our plan. We are reinforcing the accountability for the NHS trust plans does sit with their trust boards, and I know all of our trust boards are focused on that. You will have seen, just looking backwards slightly, the NHS England's annual assessment of us as an ICB is appended to the letter, just to say that this year NHS England have decided not to do what they call segment us, which would be the same approach they're taking with NHS Trust, and that's in part due to the level of change that we're going through in ICBs. But I hope you will agree the summary of feedback that is set out in the letter does set out that we've maintained strong leadership and governance in spite of the challenges, our strong performance as a system, and also the work that we've done as an ICB on tackling health inequalities and the broader social and economic development. In part, we definitely can't do this without all of our partners around the table, but given when I look across the country and also seeing how we benchmark and compare with our peers, although it isn't a sort of a mark that we've been given, I think this is a summary of a solid, strong performance, but also with some remaining areas for improvement. And I think if I was just to look forward, really focusing around how we get pathways and support that investment in primary care will be a sort of a key priority for us. And of course this autumn we'll get a 3-year settlement and we'll be able to plan for a slightly longer term period over 3 years as opposed to the annual year. And I would expect over the 3-year period that we also do demonstrate a continued shift in resources into primary care. I won't mention neighbourhood health, but I will ask Levi just to say a few words about that briefly. I do want to particularly put the spotlight on general practice. So those of you that joined our annual general meeting would have heard in the last year we've had record numbers of appointments in general practice, 1.65 million. Also really delighted with the patient survey results, which reported that 79% of all people accessing general practice in North East North Cumbria who were surveyed had a good experience in their GP practice. That's against a national average of 75%. And 2 practices in our region, Adelaide Surgery in Prudhoe and Gameford Surgery in County Durham, scored 99%, which is absolutely amazing, really, and really does kind of demonstrate, I think, how valued they are, but also the positive experience of accessing their general practice. And we have written to all of the practices who achieved over 95%, and there were many in the survey, congratulating them. We are also going to look at how we can use our learning and improvement system to go and visit some of these practices to understand actually what is getting these results so that we can share learning across the system. Just in terms of general practice, we're obviously acutely aware for our colleagues working in general practice that the 10-year plan, and particularly thinking about the future role of general practice, and we know that the government is committed to do a national review of the contract, for example, with general practice, although we're not entirely clear of the timescale for delivering that at the moment, but our colleagues in general practice have got a really significant role in leading the delivery of neighbourhood health. We've been out and about undertaking what we've called GP practice listening exercises, where we've been meeting with colleagues who work in general practice, and our medical director and myself and some other members of the ICB have been attending these, and they've been incredibly insightful. And I think one of the things I've been really struck by has been the kind of level of innovation and enthusiasm that still remains in general practice to make improvements. But equally, general practice does sit as part of a pathway of care, and the need to make sure that through either our interface meetings or the local work between general practice and our more hospital-based services, that we can continue to build relationships, but also make it as easy as possible for not just patients but clinicians to navigate the system, and the usual barriers that are faced with things like IT and systems that don't talk to each other, and the amount of time that's wasted as a result of that. So I think we've got a really significant amount of work to do there, but for me it's about how we really sort of unleash and support our colleagues in general practice to do that. And we will be bringing back a report that will set out all that we've heard through these meetings to discuss with the board, what steps that we can take on the back of that as well. I'm really pleased to report that Tees Esconware Valley have been stood down from formal quality board meetings. Members of the board will know that these are put in place working with NHS England as the regulator of NHS trusts, where there are quality concerns and issues that require particular oversight. The trust has had a quality board established for the best part of 3 years now, and it's not to say there aren't still improvements required, but they no longer meet the threshold for the quality board, and they've been stepped down from that, which is a positive step forward, but more work to do there. My report also includes an update on the review of progress made following a SEND inspection in Gateshead, which is incredibly positive. Nearly all of our local authority areas now have had SEND inspections, and we continue to work closely where improvement action is needed with our partners on that, and we take regular updates on this through various committees of the ICB. But we were particularly pleased with the feedback made since the inspection in Gateshead, and I think it really, when the parent carer forums are particularly sharing the improvements, I think it's a real sign of maturing partnership across both education, health and schools, and that's hugely positive. Just in terms, a couple of other things I just want to mention, if I may, Chair, within the report. Firstly, West Cumbria Mental Health Services. So the ICB Service Change Advisory Group met earlier this month to consider the outcome of an independent review into mental health service reconfiguration. There were a number of recommendations made as a result of that independent review, and we've asked CMTW NHS Foundation Trust to act and implement all of those recommendations, and we'll be keeping a close eye on that and supporting the trust to implement those recommendations. We've also continued a dialogue with the Health Overview and Scrutiny Committee, which met earlier this month regarding the changes that are proposed to that service and the next steps. We do expect the new service in Whitehaven to be opened and operational as the Udale service ceases over the next several weeks, but only as a result of all of the recommendations from that independent review being implemented, Chair. Just finally, I do just want to mention measles. So those of you that watch the national news will have heard of some really sad and tragic cases of the sad deaths of a small number of young children to measles. It really does beg a belief, doesn't it, in 2025 that we're losing children in this country to measles. But what we do know is this is a direct result of the vaccine uptake. Now, whilst in our region our levels of uptake comparatively are good, particularly when we compare across the rest of the country, we mustn't be complacent. We do not want to lose a young person in our region this year to measles, so we're sort of redoubling our efforts on this, and particularly around focusing areas that do require further work, working in partnership with local authorities and public health, and making direct contact with parents of unvaccinated children. My real plea would be, if your child is not vaccinated, please step forward for a vaccination. If you're concerned about the vaccination at all, please go and speak with your general practice about that as well. But Chair, that's where I end. I'm very happy to take any questions on other parts of the report.
Thank you. Other questions or comments on the Chief Executive's presentation? Anyone would like to make? Levi.
Thank you, Chair. I'll just perhaps briefly elaborate on the neighbourhood health implementation that Sam referenced in her report. So as the report flags, there was the national programme was announced on the 9th of July. We've held a number of webinars across our system and our sub-regions since the date the guidance was issued. Indeed, we had 3 sessions for Cumbria, for the north and the south of our patches yesterday. There's a lot of enthusiasm for submitting applications, and we will be supporting those against the deadline of the 8th of August. Equally, there are some parts of the North East and North Cumbria who, having evaluated, say we're committed to our neighbourhood health approaches, but won't be submitting an application at this time, and that's equally valid based on the work to date. Just to note 2 additional points on this. One, Boost, our learning and improvement community, we've been working actively with them. So regardless which parts of the North East have an application supported on the national programme, we're going to have this community of practice to support the learning and the acceleration across the North East, which I think is a valuable resource for us. Just to assure people as well, we have very good representation. Indeed, a number of board members have been on those calls, so providers, general practice, voluntary sector have all been participating. A little bit more thought we will need about our public participation as this evolves over the year ahead. And just to pick up those points about for general practice and concerns around contractual issues, we're trying to provide some clarification. We don't believe that the forthcoming contractual arrangements in the 10-year plan hinder this progress, but want to continue exploring that and support our colleagues in general practice and wider primary care. Thank you.
Thank you, Levi. Any other comments anyone wants to make? Okay, then, thank you. Thank you very much, Sam. We can move on to the next item, which is the item on the fit and proper person test compliance, and that's item 9 on the agenda. Deb Cornell, Director of Corporate Governance and Board Secretary, is going to present this.
Thank you, Chair. Yes, and so the report you have here today provides the Board with an overview and assurance on the ICB's compliance with the Fit and Proper Person Test framework. The framework was published by NHS England in August 2023 and in response to some specific recommendations made in the CARC review. So the framework, and so the aim of the framework, and say, is to strengthen and reinforce individual accountability and transparency for the board members. So a number of checks and an annual assessment are part of that framework, which is part of the actions we need to take as an ICB. We conducted that annual assessment and those checks, and all of the board members were deemed to be fit and proper as part of that process. We also undertook an internal audit. Audit 1, our internal auditors conducted an audit of the process, and I'm pleased to know that we got good assurance as part of that process. We did identify some actions as a result of the audit. However, I'm also pleased to note we have completed those actions, which is noted in the report. The assessment was submitted to NHS England by the required deadline, and a copy of that full assessment is attached for you at Appendix 1 for information. And finally, the other thing I would report, to highlight in the report, is that the report does include an update on some of the recent board appointments that we have made, which is in Section 5, for members. So really the board's just asked to receive this for assurance, and happy to take any questions if there are any. Thank you, Chair.
Thank you. Are there any questions or comments anyone would like to raise? No. Thank you very much then. That report is received. Item 10, which is the Board Assurance Framework for Q1. Claire Riley, Chief Corporate Services Officer, is going to present that.
Thank you, Chair. This is a report that the Board will be more than familiar with. In front of you is the Q1 refresh of the Board Assurance Framework. there is an updated corporate risk register and also a risk appetite statement and guidance for your approval. Just to make a note of some of the changes within the board assurance framework, from a risk movement point of view, the financial position has gone up, noting the current risks and challenges, and that will be covered in the finance report later on the agenda. With regards to high rates of suicide, noting the plans in place and the programme that is in place to support and manage this work, the risk has gone down, therefore has came off the board assurance framework. And also note the GP industrial action as a result of collective action being imposed, that has impacted on the score being reduced and therefore not above 12, therefore not included in the board assurance framework going forward. There is a new risk being added, which is linked to the ICB transitional programme arrangements, which link to the model ICB and the delivery of what is expected nationally. And there are some closed risks that are detailed within the paper, and that is mainly as a result of a revision of how these risks are being detailed within the risk register going forward. I'm happy to answer any questions, Chair, but I would like the board to approve the BAF for Q1, to receive and review the corporate risk register for assurance, and also review and approve the risk appetite statement and guidance for 2025-26.
Okay, are there any questions or comments for Claire on this report? Are you happy to approve it then? Sorry, Ken. Yeah.
Very happy on the Q1 report, but I just guess the comment around industrial action refers to general practice near specifically. I think that's going to be a wider issue now. You might want to just reflect on that going forward.
Yes, absolutely. I think it's a timing thing, Ken, but absolutely agree.
Right. Are you happy to approve the report? Thank you. Then we're going to go through the minutes of the committees of the board. They're very full sets of minutes. A lot of work goes into these committees, but the committee chairs are going to highlight the main points, given that you had the opportunity to look through the whole set of minutes on each case. So start with the Executive Committee, item 11.1. Sam Allen, Chief Executive, chairs that committee.
Yeah, thank you, Chair. So the report includes the minutes from the 13th of May and the 9th of June, where we received a number of items, including, for example, the procurement strategy, which is a separate item on the board agenda today for approval for the board. The key things that I just want to kind of highlight from it was the urgent emergency care winter planning update, which we discussed in some detail, and particularly the focus on the 7 priorities for the whole system and making sure that we've got the right focus on those priority areas. I think it would be fair to say we've had quite a lot of discussions around this, because in previous years there may have, for example, been additional funding available for aspects that we would usually have funded through our urgent emergency winter care planning, whether that was also funding to cover the costs of industrial action or particular resilience monies. We don't have that this year, because of course this year all of the money was played out as part of the operating plan. I'm pleased that we have taken the decision already to commission the acute respiratory hubs, which we are going to continue, which everybody felt alleviated a significant amount of pressure across the system, and we had built that into our planning earlier this year already. And of course we are talking about the urgent emergency care plan on the board's agenda today. We also received the Northern Cancer Alliance work plan and financial plan, which we reviewed and approved. Just to add on the Cancer Alliance, that not all Cancer Alliances are hosted in ICBs. They are in the North East and Yorkshire, and there's been some ongoing dialogue with the national team around where they fit in terms of model ICB and also funding for Cancer Alliances. There's been a request nationally that the work of Cancer Alliances is protected. I'm confident that we've got a work plan that addresses the areas we need to across the system. The committee approved that, but also will retain the right level of funding for our alliance as part of our transition to becoming a strategic commissioner. And just finally, we touched on the Health and Growth Accelerator financial plan. One other point I wanted to make was around Oliver McGowan training. We received an update on the training for the Oliver McGowan training, which is specific training for people working in health when providing care and support to people with a learning disability. There are some very specific requirements of the Oliver McGowan training that requires a time commitment, and there's also a mandate nationally that this training is required, it is mandated, and while some of our providers have had equivalent type of training, it is now made clear it is the Oliver McGowan training that needs to be undertaken. What I would say is that some of the training does require workforce to be released for a period of time, and we need to make sure that this is planned in the future. I think this will be an area of ongoing discussion in terms of how we ensure that the workforce across North East North Cumbria is compliant with this, and I would also anticipate this will be some part of organisations' capability assessments as well. Thank you, Chair.
Thank you, Sam. Any points anyone wants to raise on that set of minutes? No. Thank you very much. So Pally Hungin is the chair of the Quality and Safety Committee.
Thank you very much, Chair. The report and the full papers are available, but I'm going to speak to 2 or 3 things that I want to highlight for our colleagues. First, just to reiterate the fact that our healthcare associated infection rates remain somewhat higher than we would want, and although the committee is confident that steps are being taken to monitor this and to ensure that solutions are in place, this is an area that we need to keep watching. It's rather disappointing that we're not performing very well in comparison with the rest of the country, so this is an active area for us, but it is being watched, and I'm confident that we will be able to attain the appropriate levels, if such a thing exists, in due course. Secondly, the annual involvement report. I'm going to come back to this in a second, but this is a report which was produced by our public and patient colleagues in conjunction with Health Watch, and this highlighted some of the concerns of our public and patients, and I'm going to refer to that in a second. We received the safeguarding annual report, and I'm pleased to say that we, as an ICB, do fulfill our statutory safeguarding duties, and it's important for that to be recorded here today. Another area of concern is that our sickness rate seems to be of some concern, and you can see the numbers there, and I know that efforts are being made to dig into this and to work around the issue. To some extent, the higher than anticipated sickness rates are due to temporary staff being brought in and staff from agencies. Nonetheless, this is something that we are watching for. This has a direct bearing on quality and safety. So if I could refer back to the annual involvement report, and as the chair of the committee, I want to thank the group that brought this to our attention. And we're all aware in this room of the higher level priorities that we have, for example, in terms of reducing cancer rates, cutting smoking, improving immunization. But there are some straightforward items that the patients and public brought to our attention, and I'm just going to quickly run through them. Hard to see a dentist, which I know is being dealt with. Long waits for ADHD and autism support, mental health and hospital appointments, difficulty in getting GP appointments, communication difficulties, and information need to be easier to understand in different languages, better support when people are discharged from hospital, digital exclusion, audiology services where concerns have been expressed in terms of long waiting lists, some concerns about continuing healthcare and more support needed, and in addition to that, a great deal of public appreciation for the work that the NHS is doing. I'm pleased to say that having received this report, we were able to communicate its findings to our colleagues in the Executive Committee and to our Chief Executive. And I'm confident that we are responding to each of these concerns in a very positive way. But I did want to highlight that these are the things that concern our public and our patient colleagues, and that we need to keep notes of them all the time. That's all I need to say today. Thank you.
Thank you. Well, we've talked about healthcare infection previously because it's, as I've said before, it's a very evidence-based area of healthcare, so it shouldn't be difficult to have the right actions in place. I mean, do we know from a patient's point of view which the safest hospital is to avoid being infected when you're admitted there? Is that
these data
information available?
Yeah, the data are available, and there are one or two sites where infection rates are higher than at other sites. And to a large extent, these are due to two factors. One, I'm embarrassed to say, a lapse in personal hand washing hygiene in certain places. And secondly, structural difficulties to do with estates and high levels of occupancy. Both matters are being ameliorated with in terms of consultations as well as action being taken.
I mean, we are entering an era of patient choice, and certainly as a patient, I'd rather go into a place where I was less likely to be infected than more likely. And I really think this sort of information needs to be pushed out in a clear way that the public can make a choice and avoid places where they're at higher risk of infection. Are there any other comments or questions anyone would like to raise? Yes, Christopher.
Thank you, Salim, and thank you, Pally, for telling everyone what happens in Quality and Safety Committee, especially around the involvement report. And thanks, Sam, for recognising Health Watch earlier in the work that we've been doing. And I think we are envied up and down the country that we do have a really good partnership model working collaboratively. What I was going to ask is, like, you know, a lot of the public who come to us want to know that when they're providing intelligence, that it is having influence and impact. And I know it does say that what we provide is providing the planning and reconfiguration of services, but all the comments that Pally has raised today, is there a way that we can do more to feed back to the public? Because I'm in the fortunate position that I sit here and I see the reports, and there's lots of questions I get asked, and we provide a lot of intelligence. And we're just wondering whether, as a Health Watch network, we could do more, but we could have provided how we are having impact.
You want to say something? Yes, please, Claire.
Yeah, thanks, Christopher. I think there's definitely more work to do on that, but there's also an opportunity, and as you will recall at the Quality and Safety Committee, I discussed making sure we're really clear on the perception and reality gap, because it is very clear if you just look at some of the GP data, and there's a real opportunity of promoting some of the really good things that are happening already, but also how patient voice has shaped what we do in the future. And I think there's a lot more we can do about that, and that's something that we can bring back to board.
Any other comments? Yes, please, Kelly.
Thank you, Chair. Just to comment on the sickness absence rates there, just to provide some reassurance to colleagues here at the board. We recognise that sickness absence is an ongoing challenge for each of our providers, and we're working very closely with provider collaborative colleagues. We are monitoring sickness absence very closely, but also we are looking at creative interventions and support for staff who are increasingly challenged and working within a challenged environment. We know that 33% of our absence relates to mental health, another 33%, another third roughly is musculoskeletal, and we've got some good work which is ongoing linked to the Health and Growth Accelerator, which Chief Executive Sam mentioned earlier, which is about how we promote early intervention around mental health and how we keep people at work and keep people well. So we'll bring further updates back to the board in that, but I just wanted to provide some reassurance that it is a core area that we are looking at with all providers.
Thank you. Right, we're coming now to the Finance, Performance and Investment Committee, which Dr. Mike Smith chairs.
Thanks, Elaine. Due to the organisational changes that have been going on, most of the recent meetings have been stood down. So the most recent meeting that's reported on in the agenda pack is from April. So most of the information is now quite significantly dated. So I'm not going to go into any great detail on this. Most of the important points will be covered in the performance report coming to the board today and the finance report from David.
Okay, thank you very much indeed. And then finally, the Audit Committee, David Stout.
Thank you very much, Chairman. The slides up. There's 4 sets of minutes included within the papers. I won't comment on any of those. They're full and very interesting, really. But I will comment on some of the things we covered on the 24th of July, our latest meeting. Information governance, we received the Q1, the first quarters. Very comprehensive report on governance activity, and that was shared for information assurance, and we were very happy with that. The fit and proper person test compliance report we reviewed, and it was on today's board agenda. We routinely look at financial performance. That's an update from the Chief Finance Officer on the overall position of the ICB and across the ICS, but also we look at some other things. We look at the level of debtors, the level of creditors, waivers, debts written off, other things in addition to financial performance. That's our remit. We also looked at the last meeting at 3 deep dive visits, which have been conducted across the ICS, and that made very interesting reading. And my understanding is that the trusts concerned appreciated the information that came out of that, and of course some of that information will be spread around other trusts so they can share the benefit of those deep dives. Internal audit, we routinely look at internal audit counter fraud, and they were fine. That's going well. A few minutes about introduction of a new methodology, because it seems counterintuitive. Why can it be a good thing to have internal audit reports without recommendations for action, you think? That's what I thought when I first saw it. Apparently, there's global internal audit standards, and they actually are going in the direction of not having internal audit, but the recommendations in. Internal audit will do the audit, they'll identify the shortcomings, what action is needed generally, and then managers will identify what the specific actions are to achieve the desired result. So that might work very well, and that's the route we're going down. However, we had a full and frank conversation about there are some dangers in this. If in fact managers come up with some recommendations which will not actually resolve the issues, then we sought assurance from internal audit that they would cry foul at that stage. They would actually have a full and frank conversation with the manager, and if that didn't work, they would escalate it. So that's fine, so we've agreed that. And in any case, we agreed that we'd review this in about 6 months' time just to make certain it was working. But that's fine. You can't book global internal audit standards. If those are the standards, you've got to go in that direction. Freedom to speak up. We've got a vacancy at the moment, of course, on our Futsal Guardian, and Hillary's in the process of trying very hard to make an appointment, and hopefully we'll get one this time round. But in the meantime, Hillary's making certain that any requests that come up are dealt with. That's all I want to say.
Thank you, David. Any comments or questions for David? No, thank you. That's very thorough and a non-technical presentation. Thank you. We now move on to the Safeguarding Annual Report, and Hilary Lloyd, Chief Nurse, is going to give us that.
Thank you, Chair. I'm pleased to present our 24-25 annual safeguarding report. It provides assurance to the board with regard to the fulfilment of our statutory safeguarding duties. It has been presented to the Quality and Safety Committee and discussed in detail, as already mentioned previously. We work within a number of key legislative requirements, for example, the Care Act, and then more recently, the Working Together to Safeguard Children, which came in 2023, just to outline the changes there, very much around strengthening our multi-agency safeguarding arrangements with local authorities, police forces and the ICB as equally responsible and accountable partners. In particular, the role of the leading safeguarding partner, the LSPs, which are either the chief execs or the chief constables of those organisations, and very much emphasising a whole system approach. We are compliant with all aspects of the NHS England Safeguarding and Accountability Assurance Framework, that's the SAF, and I can report that we have good governance arrangements in place. Some key achievements, a lot of those that are outlined in the paper, but just to summarise, we have built and will continue to build on strong partnership working at all levels to safeguard children, young people and adults at risk. And in addition, we continue to be an effective partner, both in children's and adult safeguarding partnerships, and also across our local authorities, our police forces, and with our providers. And our focus on prevention and early intervention continues, and our commitment to learning. Some couple of detailed achievements I just wanted to mention: our compliance audit of all the main NHS providers to gain good assurance that systems and processes are in place around safeguarding, and also updating our own safeguarding framework. From a risk point of view, our main risks are variation across the ICB landscape. There's no particular concerns around that, but we would seek to provide more standardisation. And also capacity, just to the sheer volume of work that the statutory safeguarding partners are working to. For example, on page 12 in 24-25, we had 31 statutory reviews and 22 non-statutory, which are local reviews. The themes from them are they're shared across the system for very clear learning, and the report details our focused work around domestic and sexual violence and our responsibility, again with a new act, the Serious Violence Duty, and also the work ongoing around violence against women and girls, and work with partners to very much improve community safety right across the system. Our duties around prevent are detailed in the paper, as well as additional responsibilities around modern slavery and exploitation. And our priorities for 25-26 are detailed in the report, and these in summary are continued focus on strengthening multi-agency partnership arrangements, learning from reviews both nationally and locally, and prevention, early intervention and commissioning for better outcomes in safeguarding vulnerable people. Thank you, Chair.
Thank you, Hilary. I mean, it's a very, very important area that, if not done well, carries a lot of risk for children and adults. So thank you very much for providing the assurance that that's all taking place in the background to what we do. Could I ask for comments? I think John Pearce wanted to start off. John.
Yeah, thank you, Chair. So just to comment more than anything around the reform programme that's going on nationally in terms of children's safeguarding. So to highlight some of the priorities for 25-26, but I think particularly the family health reforms that are coming in as part of that broader national reform gives a real opportunity to link across to neighbourhood health. There's very much a locality focus to that work. It's looking at integrated early intervention for families when additional needs are identified. And I think there's a lot of crossover in terms of, I suppose, the children's element of what's trying to be achieved through neighbourhood health. There's also a strand of that work in terms of the multi-agency safeguarding arrangements and building on the working together guidance that was referenced. I think a lot of the groundwork and the core foundations are in place for that. But there will be further enhancements around multi-agency safeguarding arrangements as we go through the next 12 months and all, certainly at upper tier local authority level. The expectation is that the new programme reforms will go live from April 26 with a range of sort of shadow arrangements and development work over this financial year. So just to highlight that, it is within the priorities, but I think particularly that link across to neighbourhood health is a really important one that we can make and connect up, I suppose, two parallel reform programmes that are operating at the same time.
Thank you. Anything you want to say in response to that, Hilary?
I completely agree. I think the Family First programme will be really crucial, and it is important that we link it to neighbourhood health. I think your point's well made that if we've got two reform programmes going ahead, we would not want to run them in isolation. So that joined up approach is really helpful. And I know, John, you've already done some presentations around Family First into neighbourhood health, so that's very welcome.
Sam.
Thank you, Chair. It's a question really in relation to Prevent, Hilary, and maybe John or other colleagues have got some thoughts on this. I was just reflecting on the very tragic events in Southport, thank you, in Southport, and some of the findings that are coming out of that in terms of Prevent and the role of Prevent, which we know has been focused on counter-terrorism, but there were some missed opportunities there. And I was just thinking, is that a conversation happening locally, and are we seeing any changes as a result of it?
Shall I go first? Yes, definitely lots of conversations around those missed opportunities at Stockport, especially being that first anniversary of that tragedy. The Prevent work, I feel, has now, it's developing momentum again. I do think it went quiet for a while, but it's got more momentum, and actually some new training is coming out to really help and support the understanding of Prevent going forward, so that those missed opportunities are embedded in learning.
You want to add anything, John?
Yeah, I think probably just the recommendations of the National Review give us an opportunity to look at how Prevent is revamped, and I think probably a broadening out of the work of Prevent to ensure that it captures all young people who may be at risk, and the work that we can do with them. So absolutely an opportunity to build that into the safeguarding arrangements as we proceed.
Thank you. Any other comments or questions? No, thank you. We'll move on then. Item 13 is going to be presented by Dr. Neil O'Brien, our Chief Medical Officer. There's been quite a lot of advanced publicity on this, and I must say it is a matter of great concern to the ICB, and we're welcoming, I think, the opportunity now to have a public discussion on it, because it will be causing a lot of concern to patients receiving care and who have received care in the service that's going to be highlighted in this report.
Thank you, Chair. So today we are presenting and publishing in full, minus any patient identifiable detail, the Royal College of Surgeons commissioned report that we commissioned as an ICB to look into the breast services at County Durham and Darlington Foundation Trust. So for shorthand, as I go through the presentation, I'll refer to County Durham and Darlington NHS Foundation Trust as CDDFT. I'd also like to direct, which there is a link in the report in the pack, board members to the report that's going to the public board of CDDFT tomorrow, which again has a slightly different emphasis and focuses a little more on some of the actions and the reasons why the situation has arisen within CDDFT breast services. This report plus that report should be read together. I first want to absolutely recognise the distress and worry this will and may cause members of the public. Any individual who goes through a cancer journey has to have absolute confidence in the services that are provided by the NHS, and in the vast majority of cases and times then the NHS performs well. Unfortunately, in this case, and CDDFT have recognised that the care patients received was not of the standard that it should have been, and they have issued a public apology for that. They understand how upsetting that this has been and how deeply sorry they are for the distress that this has caused, and they have set up a dedicated helpline. The number here is on the slide and embedded within the paper. that this helpline should be an easy way for members of the public to raise any concerns, to ask questions if their care may have been affected by some of the findings of this report, and offer an open communication route with the trust. So, as I say, the contact details for the helpline and an email address are located within this report and within the CDDFT board report. So moving on to some of the background as to how we got to where we are. In 2024, CDDFT was identified as an outlier in some breast surgery outcomes. As an ICB, we regularly monitor outcomes for cancer through the Northern Cancer Alliance treatment variation work. They were seen as an outlier in the re-excision rate, which means where a surgeon had to go back to do another operation after initial excision of a suspected cancer. And they were also found to have a higher rate of mastectomies, which is the operation for removal of the full breast, when compared to their peers. As a result of that, the Northern Cancer Alliance instructed a peer review where consultant surgeons from neighbouring units went into the CDDFT and did a case review to look at the outcomes and the standards of care for women receiving treatment in CDDFT's service. That report, which was in April-May of 2024, did raise some concerns. I just want to give the board assurance that as soon as those concerns were raised, we put immediate safety mitigations in place to keep patients safe. That was in the form of a second opinion service within neighbouring trusts for women who were being considered for mastectomies. We also arranged for some external clinical support within the multidisciplinary teams within County Durham and Darlington Foundation Trust, whilst we investigated the concerns that were being raised. Following this report, and we established a quality incident group, we decided to commission the Royal College of Surgeons to do a detailed review, which was done in January 2025. The Royal College of Surgeons review, just for those who don't understand the process of it, there were two surgeons plus a radiologist from different parts of the country and a lay member visited the trust over a period of 2 days. They did notes reviews, conducted interviews with staff, looked at complaints, and also looked at their outcome data to come to the conclusions that are presented in the report today. Also, County Durham and Darlington Foundation Trust took up an offer of another GIRF to visit, which is Getting It Right First Time. This is a programme which is run by NHS England, which looks at outcome data, and that was done in December 2024. The Royal College of Surgeons report, there's very detailed recommendations within here, but it did highlight quite significant concerns in clinical governance, surgical practice, and the functioning of the MDT, which is the multidisciplinary team, which is a meeting of consultants, radiologists, oncologists, to decide on the best treatment course for an individual who is in a cancer journey. As soon as the concerns were raised, following on from the quality incident group that we set up with NHS England, we established a breast surgery oversight and delivery group, which is co-chaired by myself and the regional medical director for NHS England, to ensure that immediate necessary safety mitigations were put in place, but also to monitor any improvements as we went through the review. The main findings of the Royal College of Surgeons review was that there were some failings in care. Broadly, there were issues around auxiliary clearance where there was no evidence of cancer in the lymph nodes. Auxiliary clearance is an operation where lymph nodes are taken away from the armpit of the affected side. Usually, there is evidence that there is cancer in one or more of the lymph nodes in that area, but there was evidence that auxiliary clearance was performed without this evidence, which is not normal standard practice. Auxiliary clearance can sometimes result in significant morbidity for women, and it can cause swelling of the arm on that side. So this was seen as excessive surgery. There were some concerns raised around informed consent protocols where some women had undergone procedures and it was not clear that they were consented for that prior to the procedure. There was also referral access and staff training recommendations, and as part of the cases that were reviewed, there were 3 cases identified which hit the threshold of duty of candour. Duty of candour is the responsibility for any NHS organisation or provider to inform a patient where there has been a shortcoming in their care which has led to moderate harm. There were 14 recommendations and 3 further considerations that were within the Royal College of Surgeons report, which were around service improvements, including changes to MDT working, aligning better the services within the University Hospital in Durham and Darlington, and also to review the clinical governance within CDDFT. There was also some clear requirements for staff training and development of new protocols, particularly around the outsourcing of some of the breast pathway, which I will pick up later in the presentation. As part of the oversight arrangements, we set up a clinical review group. I attend that group, but it also involves surgeons that are external to CDDFT. They work with the quality team and surgeons within CDDFT, and the membership of that group has grown over the last few months to include experts from around the country, who coordinate the look back to ensure that we can be certain that we're picking up any woman that has been affected by some of the deficiencies in care, and that duty of candour is enacted. Whilst that clinical review group was doing its work, early in 2025, there was a patient safety incident that was identified that led to further actions that needed to be taken. And it was the patient safety incident was around the diagnostic procedures that were being taken and some of the outsourced activity within CDDFT. Just to describe that a little more, there was a separate private provider that was commissioned to provide the diagnostic pathway for women within County Durham and Darlington. Within that service, it was seen that the patient experience, also some of the diagnostic techniques that were used, were not acceptable. There were some clinics that were going on till very late in the evening, and a lot of the incidents that had been identified had been conducted within the outsourced activity. As a result of the work of the report and the clinical reference group, the immediate actions that were taken was we further strengthened the membership of the clinical reference group. So the CDDFT have recruited 2 new surgeons, which have got very up-to-date surgical practice, and they can offer women now the full range of surgical options for their breast cancer. And also external clinical leadership has been provided into the trust. And I would at this point just like to thank the other breast units across the North East and North Cumbria for the support that they have offered both CDDFT and ourselves in ensuring that we can make quick improvements to ensure patients are kept safe. There's been improved MDT processes and a governance review has been conducted internally by the Trust, but there will be further external governance reviews which I can report back to the board at a later date. Once the concerns around some of the diagnostic capacity the diagnostic processes in the outsourced activity in the outsourced clinics were known, the work in those services was immediately ceased, and that was in February 2025. We've had worked very closely with the communications departments, both within the ICB and with the Trust. And the patient helpline that I referenced to earlier has actually been open for quite some time. And it has received a number of calls. This has increased of late, obviously, with us publishing the report. And the report was also in some of the local media. The Breast Surgery and Oversight Group continues to meet every 2 weeks and will be for the foreseeable to ensure that the necessary improvements are being made, and the look-back exercise has been done thoroughly and duty of candour has been exercised where it applies. The impact on patients can be broadly grouped into 3 areas. Patients who may have had unnecessary or excessive surgery, patients who have had inadequate biopsy samples, therefore there could have been a chance that a cancer was missed, and actually that the sampling or some of the imaging may have missed potential cancers. Of the 191 incidents reviewed to date in the initial look back, 123 of those have been closed, 12 have duty of candour has been applied, and those individuals have been contacted, called back into clinic, and different treatments have been offered. And of all those patients that have the duty of candour, they have been contacted directly by the Trust. I would like to say the look back is still ongoing. This is not the extent of it. There is likely to be more, and there is likely to be more that duty of candour will apply to, but we're working through the look back in a prioritised way based on a number of clinical prioritisation metrics. But again, I will provide further updates as we go through this process over the coming months. So future plans, I've mentioned the work that we will be doing to ensure all the necessary safety mitigations have been put in place, but there still remains some further concerns. The review that we had was not specifically looking at the radiological practice within the service. From a number of incidents from Freedom to Speak Up, but also some soft intelligence and some of the reviews within the Royal College of Surgeon work, we think it is prudent to actually commission a Royal College of Radiologists review into the breast services into CDDFT. We're in the process of establishing a terms of reference of that. This work, though, does take a number of months to conclude. Again, we're not waiting for that report in order to make sure that patients are kept safe. So we've instituted some immediate safety mitigation, such as double reporting of X-rays and mammograms whilst we're doing this work. The broader governance review, the clinical governance review, will be ongoing. NHS England are involved in that. The Trust, as well, as I say, have done their internal clinical governance review, and we as an ICB will be very involved in the improvement work and to ensure that the lessons learned from this work translate across all services within County Durham and Darlington. There is work that needs to be done on our configuration of breast services across the North East and North Cumbria. Our configuration is slightly unusual in that there's a separation in some instances of our screening centres and what's called our symptomatic services. What's meant by that is a symptomatic service manages individuals who actually are presenting with a lump or a change in their breast. It is seen as best quality that the symptomatic services are very, very closely aligned with screening services. And we're working with the Cancer Alliance and the Foundation Trust Provider Collaborative to see how we can make these changes in the coming months. We continue to work with the Trust and with the Northern Cancer Alliance to improve the clinical leadership within CDDFT. And we will continue to report on the improvements that are being made and the outcomes of the look back publicly and transparently through the updates to the board. So in summary, CDDFT acknowledge that the care that they provided fell short of the expected standards and do express sincere apologies for the distress caused to patients and their families. I am assured that there have been significant steps to improve safety and quality and that we have necessary and robust oversight in place at the moment with ourselves and NHS England to ensure duty of candour is adhered to and that the look back exercise is done in a thoughtful way. A system-wide approach continues and we will continue to be open, transparent and try and restore public confidence and trust into the service. And any future reviews, including the Royal College of Radiologists review that I mentioned, will come back. And again, we will publish the findings of that in full, in public, in our board when that is available. So the board today are asked to acknowledge the findings and the actions that we've taken to date, support the continued monitoring, and recognise the patient impact and the distress that this may well have caused for people in the North East and North Cumbria. Thank you.
Thank you very much, Neil. And before I open it up for discussion, I'd like to just make a few comments of my own. But first of all, to thank you for the report. I know that you've put a lot of your personal and professional time into this since it became apparent that this serious problem was occurring, and you've worked with NHS England. So thank you, and thank you for very, very clear and thorough analysis. I think we shouldn't be in any doubt that this is a very serious failure in standards of care in a crucial area of service that has survival and life and death matters involved. So it does need to be looked at extremely carefully. And as you said, it's not over because the initial investigations have uncovered a lot of the reasons that this happened, but there are further investigations pending, and we need to make sure that those are done as thoroughly and independently as possible. And you've rightly outlined failure in three areas. Firstly, the clinical outcomes in some cases being poor, substandard or suboptimal. The way that clinical services were governed, in other words, that they were following modern protocols in this important area of service and that they were clinically assured. Well, they weren't. So there was a failure of clinical governance. And then finally, there was an extraordinary idiosyncratic way of organising the service whereby it was outsourced and led to some patients receiving care very late in the evening, which is a highly unusual situation. So the first question I've got, Neil, is what was the board of the Trust doing when all this was going on, and was it aware of any of these three areas of failure until it was drawn to their attention?
I think, it's difficult for me to answer on behalf of the Trust board. There's no evidence that they had considered any of these items within their board reports prior to us highlighting this. They have worked with us very closely since the concerns were raised, but I think the Trust do appreciate that there were missed opportunities in order to identify this, and that is detailed in the board report that's going to their board tomorrow, where they failed to join the dots in some of the early markers that could have highlighted this at an earlier date.
Okay. So just one other question, and then I'll open it up because I think others will want to comment. You've described how the service measures have been put in to make the service safe and conforming with modern standards. Do we know that this isn't happening in any of our other foundation trusts?
So we do follow up any treatment outliers, and as I've mentioned, we've got, certainly in the field of cancer, where we've got specific professionals who are involved in certain tumour groups, so lung cancer, bowel, breast, who look at the outcome data from all of our trusts. So we are as assured as we can be. Outcome data is not the full story, and we also use some of the soft intelligence from people who work within the system. But we are as assured as we can be that this is not being replicated in other areas.
Thank you. Eileen Kainer.
Thank you, Salim. Thanks, Neil. That was for the care and for the clarity of your presentation. I've got two brief questions. The first one is on clarity. You've mentioned obviously there are 191 incidents and many have been closed and 12 have been seen through duty of candour. I wasn't certain, the 68 cases that's still under review, are those individuals aware that their cases are under review? Are they aware of these issues, or is that awareness yet to come?
So patients are aware that a breast service review is undertaken, and the Trust have been quite open about that for a number of weeks and months. Women are contacted if when their case has been reviewed, there has been identified a deficiency in the care that they have received. But what I would suggest is that any woman who thinks they might be part of this cohort, if they are worried, then they should contact the Trust on the helpline that we've provided.
Yeah, let me tell you, we're all worried a lot of the time on these issues, and speed is of the essence. And again, if I get the dates wrong, I'm sorry about this, but when you're presenting, awareness first came to light in 2024, I don't know, was that February? I understand this process and there is care before information moves toward the public domain, but it's a long time from first awareness to now in July, nearly August 2025. And again, for those that are yet to, I suppose, understand that they may be specifically affected, that will feel like a very long time. Yeah. So I do understand the actions here by this board as soon as we knew. But again, I think for people who may well come to know that they are directly affected, that will feel like a really long time. Is there anything we can say about when we are able to place information in the public domain and why it takes so long?
Of course, yes. So within the paper, there's a very distinct timeline of when things were known and what actions were taken. The Northern Cancer Alliance peer review was purely that. It was a peer review. It's not a structured service review like we commissioned from the Royal College. It was very much seen as a piece of information that raised our suspicion, but enough so that we commissioned the review, but also put immediate safety mitigations in place. It's a difficult balance because obviously publishing the report as we are today causes understandable distress for the public and for anyone who may well be affected by this. We want to be, and hopefully we've demonstrated, we want to be open and transparent once things are known. The structured Royal College reviews just take time because of the depth in which they go into and the time it takes to actually produce the report, which is the main reason for the delays. Once the report is published, we then need to really understand that and ensure that we have the necessary governance in place to handle some of the concerns raised, but also be able to be clear once we go public with the information that we've got a well-structured way of managing any concerns and we don't want to raise anxiety without actually having a plan to solve it. So hopefully it does seem like a long time, and I agree with that. And could we have done it? Could we have sped things along a little bit? Possibly, yes, by maybe 1 or 2 months. But as hopefully the board are assured that as soon as we knew, as soon as alerts were raised, we put in immediate mitigations to keep people safe, and we are committed to going back and looking at every single woman who may well have been affected by this, and ensuring that any treatment deficiencies are corrected.
Rajesh Nadkarni.
Thanks, Neil, and I think thank you. I know you've devoted a lot of time on this and on your leadership along with others. As you said, Sir Liam, this is clearly a significant patient failure. And as we talk about this, along with many of the women and the families who have heard about this over the last few months, many others will be hearing about it, some of them quite significantly impacted, and their families. The questions I had sort of 3 quick questions. The first one was related to duty of candor. Just expanding on what Eileen was saying, within the paper, the Royal College review talks about 3 cases. The review the trust has done of 191 incidents, having closed 123. Out of that, I think they've identified 11 with moderate harm, 60 odd with minor.
Yeah.
And some cases still are going on. On a lay perspective, the numbers don't make sense on the duty of candor. The question for you is, are we assured, along the oversight you have, along with NHS England, that the processes followed by the trust are robust enough that they're doing not just what is expected statutorily, but just connecting to anybody who's anxious, harm has been caused, and making sure that they are supporting them?
So just to explain the numbers a little more, in the RCS report, the 3 cases that met the threshold for duty of candour were of the 40 to 50 cases that the Royal College of Surgeon review team actually reviewed. When we set up the clinical reference group to deal with the outcomes of the Royal College of Surgeons, it was actually at that point that it was discovered, and that was the patient safety incident in 2025, that there was probably a wider issue related to some of the missed sampling of breast cancers. And at that point, the trust acted swiftly to close down the outsourced activity, but then actually instigated a much more in-depth review of all of the cases that had these sampling done. So actually the look-back exercise is more thorough, and I think it will go on for some time. And the clinical team that are doing it have been strengthened by some national experts in both radiology and in breast surgery. And both myself and the regional medical director are in part of that review team as well. So I think it does feel quite robust. Because of the number of cases that are affected, it is being done in a prioritised way. So the numbers that you're presenting are a point in time. There will be more cases that are looked back, and as I've mentioned, duty of candour will apply to more. So the numbers do seem a little confused in the report. The initial duty of candour number was from the original 40 to 50 cases that were involved in the RCS review. The others have been picked up as part of the clinical review process.
Sam.
Thank you, Chair. Just a few things. Just on the point of duty of candour, and I think as Neil described, over the last just over a year that we've been working with the Trust and NHS England as the regulator of trusts on this. I think it's been fair to say, I think partly driven by Neil's leadership and curiosity, this has been a sort of emerging picture that's sort of layered on at every step. I did write to the Trust formally at the end of last year because I was slightly concerned that duty of candour decisions were taking too long. I'm pleased sort of more latterly the Trust has demonstrated full transparency and has acted, but I think probably, if in the spirit of candour and openness, looking back, this probably has taken a bit longer than I think any of us would have liked. Having said that, I can absolutely assure the board that we've acted swiftly every step of the way. I think, secondly, on limited liability partnerships and the outsourcing. So we have written to all of our NHS trusts that we commission to remind them of the contractual requirement to seek approval from the ICB if services are to be outsourced, and also to seek assurance on the effective oversight and governance of outsourced services. It's not to say they don't happen and they shouldn't happen, and in fact many of these types of arrangements have been innovative and deliver good, safe services at good value. Having said that, it's really evident there was no clinical oversight here, and I think, as you said, Liam, this was a failure of clinical governance. But I did want to provide assurance to the board that we've reminded all of our commission service providers of their contractual duties and sought that assurance. And then just finally, it's not for the ICB to regulate the NHS Trust. That is a role for NHS England. However, we have met formally with NHS England to share our concerns regarding this, and it's my understanding that NHS England will be commissioning independent governance review of the trust to seek to not only get the assurance that they need, but to ensure that appropriate learning and action is taken as a result of that.
Can I just ask you, you may not know the answer to this question in general terms, Sam, but if you were subcontracting services in a very sensitive area like this to make sure that you were maintaining modern standards of breast cancer treatment and also consultation, wouldn't you make contact with, to do due diligence on the provider, make contact with services in other parts of the country, ask what their experience before you actually engaged in a contract? Because it seems extraordinary if one of the patterns here was to see patients at 10 o'clock at night, that it wouldn't have been obvious if you'd explored how they delivered services in other parts of the country before you decided to outsource such an important service as breast cancer treatment.
I think we would expect if a provider was outsourcing services, they would undertake appropriate due diligence on the supplier of those services, whether or not they're a national supplier of services or a more local supplier of services. But you would certainly expect there to be a range of due diligence undertaken and then appropriate monitoring and oversight put in place.
Ken Bremner.
Just a couple of points. Liam, if I may, on the LLP argument or issue, clearly these things get the lack clarity when you get a lot of existing members of staff working for some of these LLPs and for external bodies as well. And that's a further thing, I think, to follow through and make absolutely crystal clear who's doing what, for who and when, and what are the governance and rules around that. And I don't know if there's any evidence of that, but I suspect there probably is in here somewhere. The other point is quite clear. It's the board's responsibility ultimately for any perceived failures in their governance, absolutely correct. But I just wonder if there's some external lessons, Neil, to be learned from some of our other regulatory bodies, and I'm looking at CQC in particular. You reference it in the report, but I'm presuming there'll be some reflection for them as well about the role that they undertake in assessing quality and safety in organisations.
Yes, and just to say also in the oversight group, CQC are members of that, and they are aware that obviously the last inspection there wasn't any deficiencies found in the last inspection in the leadership at CDDFT. So I'm sure, yes, they will be reflecting on some of that.
And Claire, I know you've looked at the degree of access to information that the public are being given on this and any support. Are you confident that everything's been done on that front for people who might be worried about what they've heard?
Yes, and the Trust continue to push out those messages. If anybody has any queries or concerns, please do get in touch with the helpline or the email helpline address too. And the more we can spread that message, the better, actually, Chair.
Any other comments anyone wants to make? If not, well, thank you very much indeed, Neil, for such a thorough analysis and action plan, and we look forward to hearing further progress on this. Thank you. I think we need to stick to the timing of our breaks because, as far as possible, the people who are listening online will have planned their time around that. So I think we have just got time to fit in the integrated delivery report, and then we will be finishing on round about our scheduled time. So that's over to Mark Hopkinson, who's deputising for Jacqueline Myers on this occasion. Thank you.
Thank you, Chair. I'm pleased to bring to the Board the integrated delivery report and ask Board to receive the report for information as well as assurance. So this is the first time the Board has seen the new look, the newly formatted IDR in 2025-26. The new report continues to provide an overview of quality, performance and finance and aligns to the new operating framework and draft performance assessment framework from NHS England. The report is now more automated. It makes it an awful lot more easier to pull together. It makes it more efficient and also with fewer opportunities for human error or for spurious activity to be included. The number of metrics included in the report has also been reduced and has been within the report. There's some supporting narrative as well to take the suggestions of the NHS England's an insightful Board publication. A broader range of metrics not included in this report are also being covered by some of the strategic programmes and contracting arrangements that we already have in place as part of our normal day-to-day business. The executive summary of the report notes key changes from the previous report as well as key points to note, and also highlights key successes and key challenges for this period across NENC. I would advise that this is the first 2 months of the year for this IDR. The IDR will be produced in full for Board and Board committees. The summary IDR will be produced for Exec Committee, and twice a year we will provide an extended IDR to include some of the metrics which refreshes less frequently. The format and content remains the same, and importantly the IDR not only provides a summary overview, it also now describes the key metrics linked to the relevant strategies and strategic groups as well, to give colleagues an indication as to where these metrics have oversight and are being addressed. So as an example to that, if I bring your attention to page 9 on the IDR around urgent emergency care, what you can clearly see is the 3 key metrics, which are A&E performance, average Cat 2 performance for ambulance services, and the number of 12-hour waits in A&E. There are some key observations within that page. It identifies the risks as well as the key actions that are being undertaken. For example, it describes the winter planning process that we are currently going through, which Neil will take us through in greater detail a little bit later in the meeting. So if I could highlight some key findings and challenges in the report, specified on page 5 in the executive summary. Mental health support teams in schools, a very key area. These teams work very closely in schools with young people and support young people on a day-to-day basis, as well as then refer onward to support services. So a key challenge for us as an ICB is to deliver these core services. It wasn't specified in the National 25-26 operational planning guidance. So as an organisation, we've had to identify how we'll deliver and spread those services widely to ensure it meets the needs of young people. Challenged elective recovery across NENC, a key part of our work. Attempting to reduce long waits, the waiting list size, and again I must say that this metric is challenged now because of the impending industrial action over the past 5 days and likely further industrial action. So again, we will be addressing that to ensure that we make rapid improvements. Whilst NENC as a system is a high performing system around urgent emergency care, I must say that one of the criteria, one of the key metrics, the no criteria to reside. We are in the top 5. We are in the top part of the country. We do have 2 trusts who are significantly challenged and who have high levels of number of no criteria reside patients who can be ready to be discharged in the community. So we are working very, very closely within the Urgent Emergency Care Work Programme to provide support, external scrutiny, and ensure that those providers, along with their local systems, make rapid improvements in preparation for winter. Areas of good practice, I've mentioned the mental health support teams. Despite the frailty of those services, we are seeing an increased number of children accessing that support, and that will continue to improve and enhance as those services become more robust and more established over this year and into next financial year. All 9 acute providers have participated in the Q1 National Validation Sprint exercise, completing 2% more RTT pathways compared to this time last year. So again, that's a real positive. And in April and May, NEAS have maintained their performance that they delivered across the whole of 24-25 and are still the top performing ambulance service across England. So they're positive. I'd also like to highlight to colleagues some specific performance areas detailed in the infographic, which is now showing on the 2 screens. Not very clear, but very clear in the report itself. So again, I'd like to highlight urgent emergency care performance. We are still a top performing region. However, I must bring to colleagues' attention the significant pressures that we've experienced over the last month or so, despite it being midsummer, where we've seen an awful lot of patients self-presenting to our ED departments and front of house departments for a number of conditions. Trusts have worked particularly well to deliver that, but the likelihood is that we may see a slight reduction in urgent emergency care performance over the next couple of months. The elective care programme, particularly number of patients on the waiting list, we are behind plan, but we are being underpinned by good performance on RTT. Linked to the top performing ICB, ICS, and we're continuing to work with all providers to reduce those longest waits. So again, we've made some good progress with regards to that. Primary care, specifically the number of urgent dental appointments. We've made significant progress with our programme. However, this metric is flagged as a risk. The target we agreed from April has not been achieved, but I think Dave would like to input into that particular target.
Yeah, I can do. And it's disappointing to see that. First of all, I should say I welcome the report and the format of it. It's really helpful. It's disappointing to see that in the performance information. There are 2 reasons for this. One is that the programme is just picking up, and we'll be talking about it later, and we talked about it at the last board in terms of urgent access. The other bit is we're having a conversation with NHSE colleagues regionally and nationally about the way they're actually measuring the input here, because it doesn't quite capture the full intent in creating the extra appointment slots that we've got. So more work to do in this. I think it probably shows, Mark, we just need to refine this, which we'll do working with your team. Thank you.
Absolutely. Thanks, Dave.
Mark, just before you go on, Mike, you got a comment on this?
I'll save it until the end.
Okay, thanks. Go ahead.
The other metric I'd like to flag to you is around the mental health metric.
You might need to just go a bit closer to the microphone or pull it a bit.
Sorry. The next metric I'd like to flag to colleagues' attention is the community services waiting list over 52 weeks, which is the mental health metric on the far right hand side of the column. The community health services waiting list submission collects monthly data on waiting lists for all adults and children. Providers submit aggregated information on service line irrespective of the numbers of ICB or regions they provide services for. So that does tend to overinflate a number of the patients who are included in this metric. So therefore, the ICB have picked this up and are working with them to put in place a much more rigorous and robust process to collect data. They are very closely working with NHS England as well, who've also identified this as an issue around validity and a clear understanding of the rationale for this metric. So there's some specific work going on locally to ensure that we are reporting as a robust and a rigorous metric as we can. So, for example, there's been some review work undertaken at a couple of our trusts who've identified additional patients, which have then been put into this metric, which has bumped it up artificially. So, Levi, is there anything that you want to add to that?
I think you've covered the key points, Mark. I mean, just to clarify on that, I think it's helpful that we're doing this kind of deep dive analysis of this metric on community weight. So it's going up a little bit before it will come down again, but that's about getting some consistency in the reports from our providers. It's also identified, as an example, there's an independent sector provider where a large proportion of their activities reported against the North East, North Cumbria, although they deliver across the country. So we're working with NHS England to do some validation. But I think it just reflects that the focus around elective recovery has been part of that national debate, and what we want to refocus in North East North Cumbria is having the same level of scrutiny and focus on the community services. So I think Chair will probably be bringing a bit more detail on the next report on some of the work streams to provide some assurance on that. Thank you.
Thanks, Levi. And the final metric I'd like to flag to colleagues in the performance highlights slide is on the bottom right-hand corner, mental health, so the total number of inappropriate out-of-area placements. In April, we saw a jump in the numbers of out-of-area placements, where we've been at around 5 or less throughout the whole of last year. The issue is actually with one of our providers, and we've worked very closely with that provider and have now resolved that, and we're more or less back down to 0. So again, Levi.
Again, Mark, I think you've covered the key points. It was a well understood spike earlier in the year in April, with a kind of a combination of increased demand, high emergency department referrals, leading to the use of inpatient beds out with our normal capacity. Again, as Mark said, some quite focused work. So that data was the March and April. We are, unfortunately, it's at 1, not the 0 I was hoping for at the moment. And what we've done with our mental health providers there is we now have a weekly monitoring meeting with them, so we get better early escalation if there's going to be a deterioration in that trajectory. So I think introduce some new safeguards to oversee against that metric.
Thank you, Levi. So colleagues have got the report for information. The board has asked to receive the report and to provide assurance.
Thank you. Are there any points? David?
Yeah.
David Stout.
Yeah, thank you very much, Chair. Thank you. On the virtual ward, it's 60.7, which is not too far away from where you want to be, but it still seems very low. And I wondered whether, in fact, this is par for the course, it should run at 60 odd, or whether, because this is an average, whether, in fact, there's actually some very high occupancies and some very low occupancies. And I wondered, what's our stance on that? I mean, it's very topical, virtual wards. I believe they're a good thing. And I was surprised that 60% is just bobbling along, unless I'm missing something.
Chair, if I may, I think help Mark with this one. I think what we've seen over the last year is quite a strong review against the virtual wards and how they're configured. If you look at all of our providers in the North East, they've had slightly different cohorts, so some very focused on respiratory, others on frailty, some on step up, step down. So with our medical director, we've done a lot of work on profiling the specification and client groups for going into this winter. It also reflects a variation in that interface at the community and general practice level, David. So again, been quite a focused piece of work there. But you're absolutely right. What that global figure mass is quite a variation in performance. It will also be part of our contractual review for the year ahead, because I think we've seen nationally that rolling forward of virtual wards from the days of the pandemic, and it does need a bit of a tighter definition on it now.
Thank you. Mike Smith.
Thanks, Mark, for the updated report. I think it's very clear in the new format. It makes it very digestible. You alluded to it at one point in your verbal report about the variation between areas, and David, I think, is touching on the same point, that some of the average figures will mask variation. I wonder whether perhaps in the more detailed quarterly report it might be helpful to have a bit of a breakdown of where there's big areas of variation to highlight that.
Sorry, I think that's a fair feedback, and I think we'll acknowledge that and we'll take that forward. I think that was always the intent as we move forward. This report will develop and we'll continue to take on board refinements and feedback. Thanks.
Thank you. Sir Pally Hungin.
Thank you, Chair. Well, I'm delighted that in many ways we are performing better than other ICBs and trusts up and down the country, but I just want to make a human point. 4 hours is a long time to wait in A&E, and it's not a great source of pride that our figures are what they are. They might be better than other people's, but they're not brilliant. 4.2% of people waited more than 12 hours. Can you imagine the endurance required to wait 12 hours? And similarly for diagnostics, 1 in 10 is waiting 6+ weeks for diagnostics, fearing cancer in the meantime. So I think we take a certain amount of pride in being better than others, but I think a certain amount of depression really in terms of the human cost of some of these delays. And I think I take the point that Mike has made. We should find out where these variations exist, why they exist, and what we can do about them. I think that's about quality and safety too.
Yeah. I mean, I think it's a really good point, and I think it shows the downside of nationally monitored metrics, because they don't necessarily tell you. And I do think with that, the insights team have been working hard on developing new metrics. But coming back to the earlier discussion about healthcare infection, there are ways of presenting the data which won't just give the patient an ability to understand or choose, but also put pressure on the organisation to perform better, quite bluntly. And I think we should be looking at possibly metrics which are more patient-orientated, what any of us round the table would want if we went to receive care. So I think it's a really important general point that we should be following up. Christopher Eckers-Belcher.
Thank you, Salim, and thank you, Mark, for the report. I do welcome the new format, and I do understand that we'll get greater detail on the metrics twice a year in August and February, and that the new format is based on suggestions from an insightful board report from NHSE. But from speaking on behalf of patients and the public, I always like to track and monitor areas of concern. And just to give an example, on primary care, number of patient appointments per day doesn't really tell me anything. Whereas if it said percentage of people who received same-day appointments or within 14 days would tell me a great deal more, so that we knew what our performance actually was, because numbers are meaningless to a lot of the public. But one of the things that I felt that was missing, which I always get asked about publicly, is around learning disability and autism health checks. And that is not going to appear, and I presume it will appear in August and February, but that's a constant that people get asked, especially with that direct correlation between early mortality for people with learning disability and that assessment that a lot of the time they haven't had the health check or the associated health plan. So I'm just wondering whether or not this is the final version, or whether there's going to look at it and it can be enhanced.
Yeah, Levi.
Yeah, just to reassure you, we were circa 79% on the last report on the annual health checks, which, as you know, Christopher, tends to be a year-end one. And absolutely, there is a deeper dive behind all of this. I wonder if we might need to take this into a future board development session. So you're right, the Insights dashboard, you can drill down behind a lot of these headline metrics, which obviously you can't do on the paper version. So I think, Chair, we'll explore with Jacqueline about some time with the board on that.
Good. Lisa Taylor.
Yes, just to point out around the more patient-centric metrics, the ICB's partnered with the VCSE partnership programme to look at developing sort of a more a broader look at how outcomes are monitored in terms of commissioning, and I think that'll be really interesting if we can link that into performance outputs later in the year after this project sort of really gets off the ground.
Thank you, Lisa. Yes, Claire was coming in as well, I think.
Thank you. Just briefly, I really like the idea of board development session. I also think that we need to be aiming to get as much of our data in real time as possible accessible to the public. So you know, how great would it be if you could see this by location rather than the aggregated performance across the North East, North Cumbria. And I think now we've got our insights team up and running, and I have to say I think they're doing fantastic work, and they've developed some tools within the organisation that we can use. We should think this year about how we develop a sort of a publicly accessible portal that drives more transparency and openness around the outcomes and performance across the various services that we commission.
Thank you. Claire Riley.
Thank you, Chair. And just taking both Sam's point and also Lisa and Christopher's point, I wonder whether or not there is an opportunity of co-producing with the public about what matters to them, and so we can be able to report on them. So whilst we will obviously need to report on the national metrics as we could create a number of metrics that are important to the patients, and making sure that we then push it out on a regular basis.
Okay, thank you, Claire. And I can see no other comments. So we've got a break now between now and 1:35, and we'll resume at 1:35. Okay, we are ready to resume, and we're returning to the agenda of the Integrated Care Board for North East and North Cumbria, 29th of July 2025, and we're on to item 15, which is the finance report, and David Chandler, Chief Finance Officer, is going to talk us through that.
Thank you, Chair. So the report in front of you is the month 2 finance report for both the ICB and the ICS. I'll go over the 4 main financial duties and how we're progressing. I'll also touch on the attachments, which include information on the spending review and the latest business rules from NHS England on finance. So in terms of the main financial duties, the first one being the ICS duty to achieve break-even on the 25-26 revenue plan. So as at month 2, as Sam alluded to earlier, we were slightly ahead of plan. However, that included the benefit of a significant land sale that happened in month 2, and it happened a bit earlier than we were planning for. So when you take that into account, we're actually £4 million behind plan. And the main driver of that was cost efficiency. So even though we delivered £82 million of efficiencies in month 2, that was £4 million less than what we'd actually planned for, and that obviously drives the if you like, the shortfall on month 2 position. And that's spread over many organisations in the ICS, and those organisations are working on mitigations to cover off those shortfalls. I would ask for you to note 2 things, though. First of all, that whilst being £4 million off plan doesn't sound so bad when you think about the fact that we, for example, in ICB have a £9 billion budget. The actual reported deficit of £19.5 million a month 2 would of course need to be recovered by the time we get to year end. Now the month 3 positions aren't in your pack. However, we have reviewed them on Friday at the ICS Director of Finance's meeting, and in there we can see we're actually back on plan. So whilst we still have a bit of a shortfall on efficiency savings, that number has reduced as well. On efficiencies, I would just take the opportunity to remind everybody the level of efficiency that was required is just over, on average, just over 6%, and that compares to the 6% or so that we had to achieve last year as well. So that's 12% in total, and there will be much more requirement for that to be a recurrent delivery of efficiency compared to the previous year as well. In terms of efficiency and risk, as David has alluded to before in the Audit Committee, there have been deep dive reviews led by NHS England, and that feedback has been shared with wider partners in terms of the learning. The aspect of deficit support, so I've included in the pack the latest business rules, and I just think it's worth bringing that to everybody's attention so everybody's really clear. This year we're expecting to receive £33 million of deficit support funding as part of those business rules. That allows us to get to break even. And the rules around that are relatively simple this year. So the deficit support is earned quarter by quarter, and we've now received the first 2 quarters of that funding. And once you've received it, you've got it. However, if we don't deliver our financial plan by year end, we have to repay it. So we would have to repay that £33 million if we were, say, to miss our financial plans in ICS by, say, £5 million. So there's that incentive to encourage us to deliver plan on that basis. The ICB duties achieve its plan this year as well. The month 2 position is always very difficult for an ICB because a lot of the data that we require to report is usually in 2 months in arrears, such as prescribing data. That being said, we're reporting a slight underspend at month 2. That is generally driven by vacancy savings, and there'll be no surprise to the board that we're holding vacancies because of the impending changes to the level of funding for running costs in an ICB. There are 3 material issues or risks that I'll just bring to your attention around the programme budgets of the ICB that the executive is actively looking to manage. The first one is in mental health, or at least it's in ADHD and ASD, where we've seen significant increase in private sector activity and there is a risk of an overspend in this area of between 10 and 15 million pounds. In prescribing, which is always a volatile area, there is a risk that the early information that we're receiving for April and May is indicating that there may be a pressure on prescribing coming through already at the start of the year. So if that falls through, we'll have to actively manage that. And then the third one is continuing care. So we do have a £30 million efficiency plan in all age continuing care. It's probably the riskiest element of our £125 million efficiency plan. And whilst it is progressing really well, there's always that danger that efficiencies don't come, if you like, quickly enough. Okay, so they're probably the three main areas I'd ask the board just to be aware of from an ICB perspective in terms of risks that we need to manage between now and the end of the year. In terms of wider financial risks, if I look at those across the entire ICS, so that's all the foundation trusts and the ICB from a financial perspective, I'd remind you that we submitted a plan. It was the most financially risky plan that we've ever submitted. It had £244 million of unmitigated risk, which is a huge sum and a huge level of risk. We have been reviewing that level of risk across chief finance officers over the last few months for two reasons, really. One, to make sure we're completing our risk returns on a consistent basis. And secondly, to see that we're able to reduce that risk to a level that we believe is maybe more accurately reflecting the real genuine level of risk between now and the end of the year. So making sure effectively we're not overstating that. And at month 3, we brought that down to £210 million. And I do believe from conversations with a few individual director of finances and the group that we'll be able to bring that down further still. That's not to say it still won't be a material level of risk, but what it does do is allow us to give us a great deal of confidence in the figure that we're reporting to NHS England and internally. The general consensus is the risk is probably more than the £100 million mark rather than the figure that we're reporting now, if you like, individually and then adding it all up. On capital, the third financial duty, the provider collaborative manages that on a day-to-day basis in the main. Month 2, it's a bit early to say too much in terms of variances. We're forecasting we will achieve that plan. We have had some additional funding to top up what I would call a very tight control total we've been given this year following a change in formula. We've received some extra funding around hitting performance targets. So, for example, North East Ambulance Services, with the level of performance they achieved last year, has allowed us to receive an extra £5 million of funding from NHS England for capital spend. Running costs, as I've indicated earlier, we are underspending on a running cost control total, and no surprise there, I fully expect us to achieve that control total for this year. I'll just touch on, Chair, in terms of what's in the appendices. So there is a briefing note there which I've shared from HFMA, which I helped produce on the spending review. I probably just want to bring out maybe 1 or 2 points from that document. The first one is the spending review for NHS England, which will trickle down to ICBs, is a 3-year, 3% real terms revenue growth funding allocation increase. And whilst that's really well received and it's fantastic to receive real terms revenue growth, I would just sort of share that from my simple maths that was based on an inflation rate of 1.7%. And most of us will know that inflation is running higher than that, and NHS inflation runs higher than that as well. So there's a danger a lot of that money will be required for things like pay inflation. Okay, so we just need to bear that in mind when we're putting together financial plans for the next 3 years. On capital funding, the second point I think is very important to note is that capital funding, and I talked about the allocation for the North East North Cumbria being reduced this year due to a change in allocation formula. Capital funding is held flat for the next 3 years. So that will give us some challenges. The Infrastructure Board estimated that we had approximately 50% of the capital that we needed for the next 10 years. And whilst we know NHS England are looking at working with Treasury in terms of having more innovative ways to access capital in the NHS, we do have a challenge if we're going to be able to maintain our infrastructure in capital, but also invest in modernisation. The last thing I would just note, Chair, is that NHS of England have indicated that they would like organisations to develop their medium-term plans for the next 3 years effectively across the summer. We're expecting more guidance on that, though most organisations have started work on that. What will be really interesting is to see is how we develop that from both an organisation point of view, but also from a system point of view. Because everybody around the board will know that the ICB model blueprint is out there. It changes how ICBs will operate in the future. How we develop plans at a national, regional and local level that work so that we're not, if you like, generating overall deficits somewhere that would still have to be managed will be interesting. So I'm sure that guidance will show us more how we ensure that the overall plan, once you bring in all the constituent parts together, are effectively affordable from an NHS England point of view. But we'll share more on that as we get the guidance out and as we continue to work on producing those 3-year plans, the first year of which I think effectively is scheduled to become, if you like, the contract and the plan for the next financial year, and probably being produced way before March 31st deadline. So sort of like bringing forward that planning arrangements for 26-27. That's all, Chair. I haven't taken any questions.
Thank you. Questions and comments, David?
David, thanks very much for that. It's good news that month 3 we're on plan, so that's good news. But the other things you said is that if we fail, we have to pay back the 33 million deficit funding plus whatever the overspend is, so it's high stakes there. You mentioned it's 210 million unmitigated risk still around, and of course the efficiency savings are probably backloaded, so we've got the chunk of them to come. Yeah, okay. So it's challenging. The question really is, bearing in mind that everybody needs to deliver, everybody individually needs to deliver, or better, for us in totality to deliver, how, and we've got no back pocket, there's no contingency reserve, how do you propose to do that as you go through the year? Because there is no back pocket. History shows that someone fails somewhere, and it's there aren't, well, there might be a few people who can put their hand up and help, but there's no guarantees of that. And I just wonder, it's an easy question to ask and maybe difficult to answer, but what's your response to that?
No, it's a really good question, David. And my response would be, so number one, you're quite right. We've allocated out all the money as part of the spending. I spent part of the control totals and agreeing plans and contracts with providers. So we don't hold a back pocket that we use to manage that type of risk. Our plan was all the money allocated out and ask people to deliver. On top of that, I would say, number one, we have a good track record of system working across the North East North Cumbria. I don't know how well it works in other parts of the country, but we've certainly seen the benefit of that, of working together to collectively manage risk. And we saw that last year where we came together and made sure we delivered this year's financial plan rather than pay back £50 million of deficit support funding. So we've got a good track record of working together. Every organisation is really, really clear. The money is the money, and the importance at a board level of delivering that financial plan, as well as all the other duties that they've got responsibility for. We have a lot of good existing arrangements in place across the ICS, whether that's at an organisation level or a system level, in terms of supporting an oversight. Okay, so whether that's internal measures that are in place and efficiency groups or what have you. But we've also got system groups as well. So we've got the Directors of Finance group, we've got the System Recovery Board that both offer support but also oversight how delivery is going. The last thing I would say is that we have agreed that we will come together around September time, where we will review the first 5 months of the financial year. We'll look at financial risk, and collectively we will look to see what we can do at an organisational level and system level in terms of how do we ensure we put the best things in place to enable the greatest chance of success to deliver that plan. Now, we know it's a really high-risk plan. We know it'll be extremely challenging, but the aim is to do everything we possibly can, within reason, to deliver that plan. So that's going to be quite an important meeting. I discussed it with the Director of Finances on Friday. They're fully supportive of that type of approach, which goes back to our system-wide working. And we were talking about the key people, if you like, to come together to do that. And I fed that back to Sam, who also asked me to bring that question to the Director of Finance as well, in terms of what's the best way and the best timing of doing that sort of thing. So whilst I can't say to you, I've got a back pocket that contains hundreds of £1 million to cover that risk, what I can say to you is two things. One, we'll continue working as a system. And secondly, we've always agreed that where opportunities do come along, so every now and again we do get, here's an allocation for something, we can't spend it as quick as we'd like, that type of arrangement and that type of money would be used to help offset risk non-recurrently as well. And we've agreed that across chief execs, for example, when we agreed the plan at the start of the year. So I hope that gives you some assurance in terms of doing everything we think is feasibly possible to deliver the plan.
Thanks, David. That's very helpful. Thank you.
Sir Pally.
Thank you very much, David, for your report. I have a rather naive question. Supposing a decision is made on political grounds or other grounds to, say, build a new hospital, and that decision is made in a year's time, I presume the money will come from somewhere. Where will it go and how will it be spent? Who's going to be in charge of that expenditure should funding suddenly become available?
So let's, if you put me in a nice theoretical place that there was some additional capital funding for the North East, we have a capital infrastructure board, which is effectively a part of the provider collaborative, but it's also got NHS ICB representation on there in terms of co-chairing. So we would have a place where we could discuss that opportunity. What would normally happen would be, here's an opportunity for the North East North Cumbria. We'd be asked for recommendations to NHS England, who would then consider those. So to answer your hypothetical question, I would love that opportunity to exist. That a situation came where we were offered 3, 4, 5, 600 £1 million. We would come together as a system and say what are our priorities via that collaborative board, and then take that through NHS England, making sure we're covering off the revenue aspects of that capital opportunity as well. And if you know something I don't know, Pally, I'd love to hear about it.
I've no additional knowledge, but I'm aware of a very powerful movement in the area where I live to replace the existing hospital with a new one. And looking at your capital position, there's just, there's not even 5 pence allocated to something like that. So it has to be supernumerary, I presume.
Well, there is the new hospital programme, Pally. So if we were lucky enough to be getting builds or new builds out of that, we would link in very closely with NHS England to the implications for both the organisation and the system. Okay.
Sam.
Thank you, David, for that report, and also David and Pally for your questions on this. I just sort of wanted to, I guess, add to David's summary of the report, but also just to signal my significant concern about the challenge that we face this year, and then the knock-on implication for future years as well, particularly when we're entering this period of planning over the medium term, over 3 years. So the good news is, as David said, we have made some progress. We are on plan. There are several ICBs that aren't, so that's good. The real risk for us is that we haven't really, whilst we have made some progress, particularly between month 2 and month 3, in de-risking efficiency plans, we still do have a high level of efficiency that is unidentified, and we still don't have the right balance between the recurrent and the non-recurrent efficiency. The two trusts in the system where we've got the most significant concerns around efficiencies are Newcastle and South Tees, and they're not small numbers, they're quite big numbers, and we also know that there's some slippage against plans as well. So I just don't think we can underestimate the level of challenge that we're facing this year. So I do think we need to be taking remedial and urgent action on this, and therefore I do think planning to pull together key leaders across the system in the month of September in order to work together on that is important. Of course, if one part of our system fails, it impacts the whole system. The implications are right across the system, particularly if we lose our deficit support funding. So I think we need to be taking urgent steps to take action now and not sort of let this drift further into quarter 3 and inevitably quarter 4. I think many of us have been around long enough now to know that if we don't get control of this by the end of September, it's going to be really challenging to deliver our plan this year. We definitely do not want to be in that position.
David, just had a question on the comprehensive spending review paper, the one with the green font at the end of the bundle of papers. And I noticed that one of the bullet points that the government is saying, investment of at least £80 million per year for tobacco cessation programmes. Well, first of all, it's not clear whether they really mean cessation programs, which obviously people sitting in a group receiving advice as to how to stop smoking. I doubt if it's that. I think it's probably tobacco control would be a better way of putting it. But, I mean, we have had a very successful subcontractor, Fresh, who have made transformational change over the last couple of decades. But the change everywhere in recent years has been incremental. It's been good, you know, very good things have happened, including smoking in pregnancy and so on. But I just wonder, given that it's our biggest killer and we're looking for shift from treatment to prevention, we've never really had a proper deep discussion on what more we can do on tobacco. And there is stuff happening around the world, I think, which in some small number of places is doing better than we are. So I was just hoping that if that's going to come out in allocations, I'm not sure if it will or it won't, we could just attach a string to it so that we can make a bit of space for a board discussion rather than just pushing it out on the contract front.
Absolutely, I'm all happy to take an action away on that one once we know a bit more about that money, where it might be directed to. You know, will it come our way or will it go to public health or what have you? I'm all happy to link in with the likes of Tom in terms of maybe working together and something we could bring back to board. And it's been proven, hasn't it, Tom, in terms of investment in these type of services, some of the most effective that you can actually do. You look at it from a cost-benefit point of view, so I can see it being a good use of board time as well.
Okay, Tom.
Yeah, just to add to that, so along with the announcements around the tobacco and vapes bill, there was a commitment for additional funding to be distributed to local authorities to support enhanced stop smoking service capacity. So we've had that funding now for the last 18 months, where we've actually put that into additional frontline stop smoking services. So it is the literal stop smoking advisor support direct to individuals who have a tobacco addiction. There is some level of top slicing that's gone into national campaigns and such. And then also at a local level, we've also combined some of that money across the local authority footprints to do some things once, like an app-based solution, for example. And then there's also been some national investment in vapes to support local areas in providing extra quit aids as well. So it is additional funding. I think the commitment, I mean, don't quote me on this fully, but I think the commitment for further funding will be wrapped into the public health grant in future allocations. But that said, obviously, we've already shown clear commitment to work collaboratively on the tobacco control agenda and the stop smoking agenda, and we would continue along that vein, really.
Yeah. Well, let me make a couple of comments in a non-judgmental way. That I'm told from colleagues around the country, I won't even refer to this region, that the money that goes down on that public health grant channel isn't always used for public health. That would be my first comment from what I've heard around the country. My second comment would be that public health is a vital part of our way of achieving where we need to get to, and the public health service isn't accountable to us in any way as far as I'm aware. So I just think it's an area that at some point needs to be looked at, because we're going to be held to account. And if the delivery arm can't be held to account, then how can we be held to account? So it's a bit of, I know it's a bit of a forthright comment, but it is something when we see some areas of population health not changing over a long, long period of time. Sam?
Tom may come in on this, but this was a feature of the 10-year plan in that public health grants and funding will be subject to peer reviews. Is that right, Tom? Yeah.
So at the moment, the grant is distributed by the Department of Health directly to local government, and it's circa £4 billion nationally. There is an assurance process that's associated with that and reporting back to the DH. But like you rightly say, Sam, I think, with that comes an opportunity for increased scrutiny and transparency around how the grant's used. So in the 10-year plan, there's a nod to a rolling programme of peer reviews with local government, as well as that enhanced reporting arrangements. So, and I think, going back to the principles of collaboration, we've shown that we're really keen to work hand in glove with the ICB through Healthier and Fairer, and then at the place-based level as well. So I think, speaking on behalf of DSPHs for the region, we'd be really keen to keep doing our business in that way, in a transparent way around the investments and how we could get the most out of those at a local level.
Yeah. Okay, but in a neutral way, I'm sure through the strategic commissioning channel that we've got now, some of our FTs would be delighted if we judged them on their peer review discussions rather than whether they're actually delivering something or not. But that's just me. Perhaps I'm getting a little old for seeing some of these mechanisms not changing very much. Okay, and item 16, the Intensive and Assertive Community Mental Health Care Action Plan update. For those of you who remember the plan before it was updated, you've now got the update. Levi.
Thank you, Sir Liam. And as you say, this follows up from the original assessment of this that we brought in September 24, and then builds on the further work we've done with our provider trusts. It also references, as people will be familiar with, the independent review of the homicides in Nottingham that came out in February this year, and some of the NHS England intentions from there, including developing some future gold standards around this work. So I'm going to use the slide deck to take you through some of the key points, but there's a lot of detailed information in the paper, including the appendices, which give you the full updates from our providers, which should be one of our main assurance routes, having been through their provider boards as well. But it will be an area that I'm sure board will want to consider further. So, assertive intensive community mental health care. So, for people my age and similar in the room, we used to call this assertive outreach, but now assertive and intensive community mental health care is the how this is framed. And really, as the slide demonstrates, it's people who need assertive and intensive care who've got severe and enduring mental illness. We do know, and again the Nottingham report identified this, that this is a community of individuals who can be difficult to engage with the old language. What we would say now is that the services need to work that much harder to make sure we are engaging them, we are keeping track, we're making access as equitable and as easy as possible. So it's really our system's duty to offer these different delivery models that really support people improving access to the services in a way that works for them. And this community of people are really at risk of harm and can be vulnerable in many instances, and we see this whether this is about medication compliance, alternative psychological therapies and relapse, and therefore this is where we see, as the Nottingham independent review identified, the risk to others can then appear. So in terms of who delivers assertive and intensive care in North East North Cumbria, as we previously reported, so Cumbria, Northumberland, Tyne and Wear, CNTW, and Tees, Escombe, Wear Valley, Tuve are our two main NHS foundation providers of assertive and outreach functions. This is the only exceptions to this will be older people's community services in Gateshead, which is provided by Gateshead FT, and similarly in North Tyneside, hosted by Northumbria NHS Trust. So all 4 of those trusts have been engaged both in this review work, in our action planning, and again in the appendices you can see how they provide their provider assurance routes as well. Within CHUV and CNTW, as you would expect, we operate a model of care that is more embedded around that wider community mental health function. And this is part of the ongoing debate locally and nationally about where does this sit as a separate function? Can it be integrated into core mental health provision? And the system's really keen to see enhancements so that being less prescriptive where this assertive and intensive function sits, but making sure there's really good visibility on the individuals who need those services. How are we tracking them and assuring ourselves that their needs are being met? And the team have also done a piece of wider engagement work here. So we've worked with our local authority partners, and adult social care have been a real key collaborator in understanding this work with our providers. Just to give you a sense of the national ask that we've received, so as we reported in September last year, the paper that came to board gave the early findings of that work, and that was the original piece of work to identify gaps, potential gaps in service delivery, and provide some initial assurance, particularly about those engagement functions from our providers with this client group, and particularly their DNA, their did not attend policies. So if somebody doesn't engage with services, what are the mechanisms for tracking them, for staying in contact, and again, for making sure the service offer is responsive to their needs rather than expecting them to fit in with how we deliver services. In October of last year, myself and Rajesh, we did that further board development session where we looked into this in a little bit more detail, including the homicide inquiries and learning from national inquiries. And then in November, the end of last year, we had a further ask from NHS England to do some initial analysis. Where did we think there were potential gaps in service, and how might that identify a national spending review? As you'll remember, we shared this, I think it was through the Chief Exec's update last year. We submitted that in line with the required timescales, and we were mapping this against what were then called the national fidelity models of supporting people in community settings. As mentioned earlier, Claire Murdoch, the National Director for Mental Health, asked us after the Nottingham inquiry was published in February to do some further action planning. So this was subject to some regional and national analysis, building on the recommendations of the national inquiry, and our provider trust then did some more detailed work to reanalyse and review the action plans we'd done last year in light of the inquiry findings. So that brings us to July, to the current board meeting. So the paper, as I say, is to hopefully provide board with some assurance of our compliance against the national ask, but also for us to consider our North East North Cumbria wide commitment to ensuring that we are really focused on the actions that will make a difference for this population and for the wider community. We are waiting still the national being referred to as gold standard guidance that will refine this model. We were expecting it in July, but at the date of this meeting, we haven't had that detail yet. And similarly, there's been no further clarification on any dedicated funding for expanding these models in the future. So whilst we wait for some of this from the centre, what we continue is our local system and provider action planning. Just to really reinforce for you the findings when we did our review work, really it did reinforce that there was some variation in the clinical models across our providers, and particularly in terms of clarity of where the assertive and intensive functions are both needed and located. It also identified in terms of cohort identification some complexity, depending where that function is delivered in a provider, of being really clear of how they are identifying individuals who are at risk or would benefit from services, and again, that ongoing continuity of care and tracking for them. And then the third of our key findings really was this variation at points of transition. So whether that's somebody who's newly been identified through access with crisis services or perhaps with general practice, and they're being handed to another provider for a more intensive support function, we identified that there were risks at that point. And you might see that in the example there, you know, people transitioning from adult to older people services, for example. So what did we do locally? So we've continued with our action planning in two ways, really. So the first way has been, what can we do as an ICB system-wide actions? So the team have pulled together a system-wide task and finish group working with our providers. That reports into our mental health and learning disability subcommittee, and that's really focused on the things that we can do at scale, that we can assure ourselves at scale. And the second part of this has been the local actions. So the provider trusts, as part of their delivery responsibilities, have to keep their operational action plans refreshed. And as I say, the appendices demonstrate for CHUV and CNTW, where those have been through public board meetings for the assurance function. For Gateshead and Northumbria, these have been through the quality committee route, given that they have relatively small numbers of individuals accessing these services. And so collective progress, just to give you a bit of a sense where we've got to. So we now have had the assurance in terms of cohort identification. So our provider trusts have provided assurance that they can identify the cohort of people with an assertive and intensive outreach, that they have got systems in place for tracking engagement and a clear escalation policy if there is disengagement from services. All of our providers have updated their policies. This is in line with the guidance we've had nationally and the review work we did last year to reflect best practice in engagement and management of this group of individuals. We've also had the analysis of our current workforce capacity and skill mix. Again, people who've worked in this field for a number of years will remember when this was established as standalone assertive outreach teams, same time we did home-based treatment, intensive outreach. They over time have become more morphed into generic mental health services, and the risk there is that you lose some of that particular capacity and skill for working with the most complex individuals. So again, work with our providers to do that mapping, identify any gaps in terms of delivery for this. And we're going to have to consider this information as a system to see where we might need to do either sharing some skills between our providers or informing that wider workforce and training planning, both at a North East North Cumbria, but also wider North East Yorkshire footprint. We've been piloting these integrated models, so Northumberland and Sunderland have both been working with CNTW and Adult Social Care to test out a slightly refined integrated way of working to support this delivery. Been embedding the risk management framework, so all of our providers have led on this development. As example, CHUV's been developing a complex case board where senior clinical input and oversight provides a space for more robust discussion. So it's given us some assurance this is not just, yes, we've got a list of people, we know who they are, we're actually monitoring how they engage and where there's concerns about that escalating to a more senior clinical approach. And this is a really important factor in terms of ensuring we've got good oversight of service users, but also of case mix, case loads, and making sure that services are able to safely support and manage people's needs. Something that we've had long-standing in the North East, but has been a real help here, is our growing peer support workforce, particularly in adult community mental health care. And both of our main mental health providers have really grown that peer support workforce, have executive board level roles, providing assurance about peer support. And this is a really important part of that way we're evolving our workforce model. We know that people with lived experience are provide a vital role engaging with individuals who sometimes have found traditional services more difficult to work with. And so bringing that lived experience voice as a kind of equal partner in service redesign and delivery has really made a big difference. And then finally here, in terms of ensuring that this is aligned with both the work on the ICB quality strategy and then, as you mentioned earlier, Sir Liam, the work around our patient safety centre in the future. How do we make sure that our services and our quality strategies we've got good visibility, that we learn from any adverse events, any near misses, and we respond in a timely fashion. And then just finally to give you a sense of the work over the next 12 months. Again, there's a lot more detail in the paper and the appendices, but just to summarise, we'll really be doing some wider system review of this cohort of individuals. So build on the work with the provider trust that they've undertaken, some plans around reviewing all our systems data against assertive and intensive criteria. Are we really confident this full cohort of individuals have been identified? Could people slip through the nets? How do we work with, again, local authorities, housing and other providers? So that we've been doing a lot of work on our data systems around coding that aren't reliant on manual systems. So some digital flags are being developed for this. Enhance information and partnership working, so again, both through our subcommittee but also our provider collaboratives in mental health, make sure that we keep sharing the learning, the improvements, but also as we get into some of the delivery plans associated with the 10-year plan in the autumn, we'll expect to see more detail coming around some of the mental health components, so use that forum there. Once the national guidance comes out, we do hope it will be in the next few weeks, we will do a further review to make sure that that enhanced guidance in line with our local policy development, our plans with our providers, as I talked about earlier. And we'll probably reconvene with our partners in the autumn to have more of that detailed discussion to provide the assurance against this. Continue to enhance the lived experience role, again, being really vital in terms of challenging our traditional ways of delivery, helping us understand the best ways to engage with people. We'll evaluate the pilots that are currently taking place locally and nationally, particularly with social care, and that builds into our learning. And then, as I say, making sure the patient safety reviews through provider quality committees, but also our ICB quality committee are well cited on any adverse incidents or near misses, so we continue to learn from that. And this will be built into our transition work, so we do not lose sight of this over the coming months. So I think that is a fairly comprehensive summary. I do want the board to feel assured that there is a lot of work focusing on this vulnerable client group, and we propose that we will probably return in February next year to provide a further update once that national guidance has been reframed. Thank you.
Thank you very much, Levi. 2 points before we take questions and comments. Firstly, there are a number of you who have conflicts from this item which are listed in your register of interest, but they don't prohibit you from being part of the discussion. So Rajesh, Nat Carney, Tom Hall, David Chandler, Sam Allen, Hilary Lloyd and Kelly Angus are all named on their conflicts of interest. And then secondly, we've received a number of questions from members of the public about this agenda item, and I wonder if we can just hear those first, because they can then influence what you might say when you raise your comments and questions. But Claire's going to handle that.
Thank you, Chair. We've received 4 questions on this item from Keep Our NHS Public North East, and this is set within the context of the financial challenges and the cost reduction targets that each organisation has. So I'll take each question in turn and I'll move to Levi to respond to them. The first question is, have all of the 4 NHS trusts been required to cost out their draft action plans?
So the answer to that is yes. CHUV and CNTW provided the information in November last year in terms of that review work I've described, and this was about estimates of cost to require the gaps against the previous national model. And we did share this with NHS England at the time as required, and that's to help them understand at a national level what they thought the investment might be to move to the refined assertive outreach model on a national basis. As I referred to earlier, we've not had any feedback directly on that yet. For both Gateshead and Northumbria, they did do the action planning, but given the relatively low number of people in their cohorts, we didn't do detailed costings for those 2 providers.
Thank you. Next question is, given the current financial constraints, does the ICB expect that further funds will be made available from the government for major service transformation, and will this additional funding recur annually?
So at this stage, we haven't had any national confirmation of additional funding being available. We'll continue to monitor that and, of course, would play that out in an appropriate way.
Thanks, Levi. Question 3. How and when will the ICB make public any differences between the estimated costs from the trusts and the actual additional funding received from the government?
I suppose until we do receive any additional funding, it would be difficult to provide details on any gaps, and I wouldn't intend to share those estimates that were done last year. That's part of the national planning. But if there's our next progress update in February, if there's been any further clarification, we will include that.
Thanks, Levi. And the final question, and it is a long one. What impact will any major transformation of services within assertive and intensive community health, mental health have upon the same or other areas of service delivery within the Mental Health Trust? Please provide links to or copies of the impact and risk assessments. We fully understand the principle that it is crucial to continually look to ways to improve services to meet the needs of clients, but we are also interested and concerned about any potential reduction in clinical services or staffing that may be brought about by the requirements to make these identified changes within assertive and intensive mental health.
So at the request of the national team, what we've done to date is focus on the low and no cost actions that were identified in the reviews and the action plans that we brought through the committee last year. I think, trying to get the sense of the question, we've reflected, major transformation does pose challenges, as we've heard on the last paper, both in terms of system finances and workforce. So we would continue to work with our provider trusts as an ICB on mitigating those risks. We continue to stay close with the regional and national teams on this work, and as I hope the paper today illustrated, triangulate that with national, local mental health transformation projects, national inquiries. It's linked very closely with things like our inpatient quality transformation work, which our providers are all part of, community mental health transformation, the national drive to move away from the previous CPA approach, the forthcoming Mental Health Act changes, Section 117 transformation that's happening with our local authorities. So we continue primarily through our mental health subcommittee to take all of these things together to try and make those connections across the system.
Okay, thank you very much. Are there any other comments or questions that anyone? Yes, Rajesh Nadkarni.
Thanks, Levi. Before the question, just a general point to make is, if we do this well, which is manage people with severe mental illness assertively, actually will make the mental health bound go much further, because I think that would reduce the admissions which happen appropriately at the moment in crisis and so on. So these people already require service within the system. They don't get a good service. If we do this well, I think we will make the mental health services much more better. That's the first thing. given the questions we had on the money before. The comment I wanted to make was we are waiting the national guidance, Levi, but if we don't get any clarity over the next few weeks or months on how the cohort is being identified, then as a minimum we will need to ask our 4 providers to come together and say that they have to work within a kind of framework that they are in agreement with each other about what this group means. Because what we can't have is the clinical models might slightly vary, the care pathway issues I can understand, but we can't have is one provider saying that somebody in this cohort doesn't require this service, whereas somebody else says, well, they meet the service. And that probably is something we need to take forward if there is no clarity from the national guidance, which is due to come soon.
Eileen Kane.
Thank you, Levi. A key issue here is understanding this population who need to be recognised and then well supported and engaged with. I guess I wondered about the issue of incident cases and also individuals who may not be on our radars. I do a lot of work with homeless populations and substance using populations. So when you're using system data to identify your cohort, you're looking at those already known, already diagnosed, already in the system. So incident or new cases become an issue. How and in which way do we find out about newly diagnosed or incident cases or people moving into our region? And then also you've got some groups of our parts of our population without registration with a GP, who may be homeless, who may have compounding challenges. Have they been part of this review work?
Could I perhaps pick up those 2 points? I think there's a bit of overlap there. So, I mean, I would agree, Rajesh, we don't wait for national definitions and guidance to give ourselves assurance of where we've got gaps, undertake remedial action. So, and you'll obviously be aware that that work on both the definition and cohort scoping has been a key factor with all of our providers. And I think maybe there's a helpful suggestion there that we regroup in the autumn and continue to assure ourselves there. On that second point, Eileen, I think particularly that's our work with our social care providers who often, whether it's through, as you say, homelessness or whether it's substance use or whether it's the police through breaches of peace or things we've seen with right care, right person, who are not individuals are necessarily already in contact with mental health services directly, but there are aspects of their presentation that have put them into contact with other services. So the pilot will be coming in the autumn from the work we've done with social care, which I think will be a key factor in identifying, as you say, people who are not necessarily known already to services.
Sam.
Thank you very much, Levi. I just want to support Rajesh's comment. We certainly shouldn't wait, I think, for the national guidance. We definitely need to be addressing the variation in the model. The bit that I've sort of been quite preoccupied with is in the summary action plan, the 2-phased approach to the definition and cohort scoping. So in the plan we talk about phase 1 is in progress and phase 2 was due to be completed in Q2 this year. We're a third of the way through Q2. So I suppose it's just that assurance that we are going to conclude the scoping to absolutely have identified anybody who may well be eligible for this type of service. I also think in the 10-year plan there's mention of developing modern service frameworks. So those of us that are around back in the early 2000s would remember the National Service Framework on a certain outreach for mental health. I really do hope this is one of the early modern service frameworks because I think it would be incredibly helpful. But if we've got no indication of that coming nationally in a timescale, I think we need to set our own timescale. And then just finally, the point, and I think the questions were very helpful around funding sources. We are going to have some choices to make when we set our plan for next year, particularly where we invest in mental health. And we had some difficult choices to make this year. But what I don't think we should be doing is underfunding the services for people with severe enduring mental ill health at the expense of some of the more common mental health problems. And I think that's going to be some of the options we're going to have to look at as a board and where we put our investment through the system.
Thank you very much, Lisa. Lisa Taylor.
Thank you. Just to confirm for the meeting records that the voluntary sector is involved in all of this work. Just I know that'll be a question that's asked of me, so just to preempt that.
Thank you. I don't see any other comments, so we can move on, I think. But thank you to Levi, it's a very thorough report and good progress. So thank you very much indeed. On to the winter plan now, Neil.
Thank you, Chair. Yeah, okay. So I'm delighted at the end of July to bring the board our first draft of the winter plan for 25-26. There was an ask from the National Urgent Emergency Care plan that the winter plans were developed much earlier, and I think we're probably about 2 or 3 months earlier in the year with our planning than we normally are, which I must extend my thanks to all the team who've really pulled out the stops to get this to the position that we're in at the moment. So on the 6th of June, NHS England, the Department of Health did publish the Urgent Emergency Care Plan, of which there are a number of recommendations that are detailed on this slide. It's about getting Category 2 ambulance performance within 30 minutes, eradicating the lengthy handover delays to below 45 minutes, reaching a minimum of 78% on the 4-hour standard for A&E, reducing the number of patients waiting over 12 hours in A&E so that occurs less than 10% of the time, reducing the number of patients who remain in ED for longer than 24 hours waiting for mental health, tackling delays in patients waiting once they're ready to be discharged, and seeing more children within 4 hours in A&E. Now, as you've heard previously in the performance report, we are performing reasonably well in some of these, but not all. Obviously, more pressure is put on the urgent emergency care system during the winter months. And this plan that we're presenting today seeks to try and address some of those issues. So our approach to establishing a winter plan is we've established a new group this year, which is the Winter Planning Delivery and Assurance Group, and that's chaired by myself. I co-chair the Urgent and Emergency Care Network with Sean Fennick, who's a renal physician and also the Chief Operating Officer at STSFT. And our network is a network of LADBs, which are local A&E delivery boards, and we work hand in hand with the Living and Ageing Well Partnership, who look more at the kind of community response to urgent emergency care, along with the Urgent Emergency Care Network. But what was happening, we felt that we could strengthen our planning for winter by setting up a new group that sat in between those, drawing together all of the key initiatives that we think would make a difference for this coming winter, and overseeing the delivery and just getting a bit of grip on delivery of that. All of the plans that we have are built up from the local A&E delivery boards, and the A&E delivery boards have got wide stakeholders on there from voluntary sector, social care, primary care, secondary care. So there is some assurance there that we are building the plans from across the entire system. So in a nutshell, this is the slide I want to focus most of my time on. We've spent a lot of time honing down our priorities for this coming winter. As Sam has already mentioned, we are in a more difficult financial position this year, so we haven't really got a lot of money to pump prime any new winter initiatives. So we're trying to develop those within those constraints. We like to set some very clear priority areas for the system, and the feedback from A&E delivery boards is that's very useful for them to try and focus where they want to put their efforts, because you can imagine there are quite a range of initiatives that you could try and develop and improve along the whole urgent emergency care pathway. But by focusing on these three broad areas, we're hoping to have the maximum impact. The first one is enhancing the respiratory pathway. It's well known that the urgent emergency care system, the added pressure, the vast majority of that is due to the increased incidence of respiratory illness during the winter months. In order to respond to that, we're taking a number of initiatives. Kath Monaghan, who's one of our medical directors and a respiratory physician, is leading a whole system improvement approach for the respiratory pathway. We're looking at a targeted, proactive care approach for people who have got long-term respiratory illness in the community, working with a pharmaceutical industry partner to focus around 50 GP practices of the greatest need and run individuals through what's called an optimise programme, which looks to optimise their overall health, put them through rehabilitation, look at their inhaler use, vaccination, smoking cessation, to try and keep them well during winter. And that programme of work is starting now in the summer. We've already heard that we've agreed to commission the ARI hubs this year, and a new service specification has been developed for those to maximise that offer, but also start to look at where the opportunities are for step up and step down and how they link in with our virtual wards. So it'll be a whole pathway approach to respiratory illness for this coming winter. Then there's maximising the preventative or home-facing offer. We've got quite a comprehensive vaccination plan now. We've embedded all of our place-based vaccination groups and working to increase the uptake at the at-risk populations, and indeed the flu letter just landed last week. Implementation of care coordination hubs in all of our places. It's fair to say they're at different stages of development, but really trying to focus the care coordination along the lines of respiratory illness and frailty, and learning from each other to try and improve for this winter is within that priority area. And then looking at the principles around the urgent treatment centres and how they all operate within all of our places as well is an area that we're looking at. And the last one is improving hospital flow and discharge. So developing alternative pathways through the emergency department for people who are in a mental health crisis, looking to implement the 45-minute absolute maximum threshold for handover, looking at internal professional standards. And by that we mean how specialty teams work together within a hospital in order to take patients out of the emergency department, therefore improving flow, infection prevention control standards, and then maximising the use of alternatives through same-day emergency care. So quite a broad series of number of initiatives, we think, and we've got a very practical plan that sits underneath this of actually what can we achieve within this year. However, there are some risks in the delivery of our plan. I've mentioned the lack of winter funding, which does limit the initiatives that we could potentially put in place to mitigate some of the issues. But in order, I guess on the other side, we have agreed recurrent funding for ARI hubs. We've optimised with industry where we haven't got funding to do our proactive approach. But we are developing business cases in the background. So if there were to be any last minute national funding that came down, then we're ready to utilise it. Some of the low vaccination rates that we've had in the past that can impact both staff and patients. But what we're trying to do is get on the front foot with our comms campaigns, working with the chief people officers to see what initiatives we can do to try and improve staff vaccination over the winter. The industrial action, We know that there's a mandate for 6 months. We've got a well-coordinated approach now to try and manage some of the risks around the industrial action, but it could have a risk to the delivery of this plan. We're looking at also some of the physical estates that limit our ability to deliver an enhanced SDEC or urgent treatment centres if the physical estate isn't there. That being said, there's been some national money that has been agreed through the National Urgent Emergency Care Capital Programme because we had some quite high performers in our area, and also there's been 2 new co-located urgent treatment centres that are due to open before the winter, and that's Newcastle and Carlisle, which will hopefully improve our performance. Comms, hugely important, trying to get the messages out, to use services wisely, to get immunised, to think pharmacy first. All of these are brands that we've really developed over the years, and you see them all over Newcastle and other places in the northeast when you're out and about. But being targeted with our comms approach with certain patient groups, and we're working very closely with comms to do that. And each of the leads of all of those 3 priority areas are working up specific plans with comms to get as much impact as we possibly can for winter. So we've got the first draft of the winter plan here today. We're going to start delivering this plan. This isn't the final plan. It'll come back in September because we're going to do a number of regional and local stress testing, kind of tabletop stress testing of both this system plan, the LAD-B plans, and we're also looking towards the provider collaborative to see what kind of cross-referencing of hospital winter plans could be done to try and improve resilience. We'll come back in September. There's a deadline that NHS England have set to get the winter plan signed off through boards by the 30th of September. We'll be well within that. And then really from now, I would say, onwards, we're starting to develop the delivery of some of the aspects of this plan, but we'll come with a detailed delivery plan when we come back in September. So that's the update. I'm happy to take any questions.
Thank you, Neil. Questions, comments? Ken?
Just make a quick one, Neil. As you know, GIRFT have been doing the rounds on all our hospitals in the last month, apart from Northumbria, I think, on UEC in particular. So do you see the outcomes of all that work, or is it left to individual organisations to take forward?
The GIRFT reports do mainly come back to the providers for action, but there is a GIRFT oversight group where all the reports are collated. We'll try and collect them all together, pick the themes and pick them up through the Urgent Emergency Care Network.
Christopher Ackers-Belcher.
Thank you, Neil, for the report. We've discussed a previous ICB around the comms, and I noticed within the plan says there's some new resources, and I do welcome the fact that the Learning Disability and Autism Network has been looking at a specific LD winter plan and focusing on flu vaccine, but later on it talks about working with public health for new resources in alternative languages, and then moving into getting that distributed through community champions and partners. And is there any thought about, before the finalise, whether there's going to be any co-production with partners, like, you know, on the resources? Because some of the discussion previously is that some of the comms wasn't hitting where it needed to, and some of the messages like Be Wise, Immunise was a bit not well received. It wasn't clear enough, and what's happening with that, because early sight of that from our perspective in the network, we'd rather, like, you know, be there from the very beginning. And just one other question just before I finish: the early distribution of electronic consent forms to schools, did that actually happen before schools closed?
I'll leave Claire to pick up the comms side. I think the early distribution of consent, I'm pretty sure, did happen. I can certainly talk from personal experience. I got mine from my children before the schools broke up.
On the comms point, Christopher, absolutely. By nature, what we do tend to do is do quite a bit of market testing around the messaging in any way. And we've certainly done that with the vaccination campaigns and the Be Wise, Immunise. Certainly the evidence that we've got, and be worth sharing it with you. But the more we can do, the better it will become. So as far as I'm concerned, if there are other things that we can do, we're more than welcome, willing and able to do that.
Have you got a metric for these respiratory changes that you're going to introduce? They sound interesting. Will we know whether they've worked or not?
Yes, we've got a number of metrics for all of the initiatives to see if we can measure the impact on those. We'll bring those back with the delivery plan, but they're still in development at the minute. But we've gone very much through a pragmatic approach. What can we do? What can we measure in impact? So yes, we'll bring those in September with the delivery plan.
Okay, and another quick question. Given the earlier discussion about healthcare infection and the amplification effect of respiratory viruses in hospitals, do we have data for the level of secondary infection in the winter? Because there'll be quite a lot of patients coming in to hospital that will be passing the thing on to other patients in hospital.
Yes, I'm trying to think if I've ever seen the in-hospital transmission rate for flu and COVID. During COVID, the pandemic, we did have it. I'm not sure if it's routinely reported now. I'm not sure if anyone... Is it, Mark?
Yeah, there's a report which comes out each Friday from... There is a report which comes out each Friday on the infection rates and the prevalence within our trusts. It comes out from UXA.
But is it in-hospital transmission?
In-hospital transmission as well.
Not just number of people
Not just
in?
community, yeah.
Okay. So it'll be the UK Health Security Agency. We can look at that again, through hospital-acquired infection.
Okay, thank you, Sam.
Thank you, Chair. Neil, and maybe Mark as well, I was just sort of reflecting on the industrial action over the last few days, and obviously that's identified as a risk. And the likelihood of prolonged period of industrial action and how we mitigate all of the risks that go with that, first and foremost, obviously, to patients, the additional impact on our workforce, but also the inevitable financial risk as well. And in doing this further bit of work in September, will you be doing any kind of modelling of the impacts of that so we can get a better quantification of that as a board, which I do think we're going to need going into the sort of the final part of the year from the planning perspective?
Okay, I mean, that's not currently in the work plan, but we can do some financial modelling on that and bring it back. The main reason for bringing this plan early is to try and get board feedback to get it to the best place it can be by September. So we'll pick that up, Sam.
Okay, I think the so-called vaccine hesitancy on COVID this year is going to be worse. And given there's been a lot of publicity about it, it just depends on whether that's going to affect the strategy at all, but it's certainly worth thinking about. Okay, thank you. And thank you very much, Neil, and we look forward to seeing the report. It's got to be formally submitted before the end of September, hasn't it? Okay, so we've got to see it again before that. Right, now on to the next item, which is the oral health and dental strategy, and David Gallagher has got that item.
Thank you, Chair. Colleagues will recognise the fact that over the last number of months we've had lots of conversations around oral health and particularly dentistry, and we've probably focused largely on dentistry. So this is an attempt to pull together a whole range of things that we've been doing with partners to look at dentistry, yes, but around oral health as a whole. And we've pulled that together in a strategy, and probably two statements to start with. Why bother is probably the first question. Well, actually, we know that poor oral health doesn't just affect physical health. It has a tangible effects and impact on education, employment and wider social life. And that's one of the reasons that the combined authorities are interested in getting into some of this linked to poverty and other areas. So we've got a vision now. It's to improve oral health in the North East and North Cumbria by reducing inequalities, preventing dental disease and improving access to high quality NHS dental care. So not just about picking up the pieces, if you like, with the care, but also trying to get people into a better position, almost as a microcosm of the work that we do across the ICB. If we look at where we've got services delivered as a starting point, we've got, as it says there, over 300 dental contracts across the North East and North Cumbria. The vast majority of those 281 are general access contracts, your dentists that you go to, but we also have urgent dental contracts, we have community dental services, and also some additional services that provide specialists, including orthodontics. So that's the bit then. There are some challenges there that we've rehearsed as a board previously. So you can't see that very well. In essence, what that is indicating is that there are some national challenges, which is the box along the bottom there, and some of the reforms that are needed to actually improve, particularly general dentistry, particularly around the contract. And there's some things in the 10-year plan and some noises nationally that suggest that is going to happen, but it's not going to happen quickly. So what we've focused on is the impact of those issues, and particularly on the dental contract holders. The challenges that we've got nationally are creating problems for providers of services, making some of their services and their businesses quite fragile. So there's a whole issue there. That's compounded by some of the workforce challenges that we've got, as we're well aware, partly because we're losing experienced general dental practitioners from the NHS, but also because we're probably not making the best of non-dental staff, or non-dentist staff rather, oral hygienists and therapists who, if we support them to develop more, they can pick up more work from dentists, which will help address some of the crisis that we've got. And the box on your right, as you look at there, the NHS dental market is quite fragile. So it's really hard to get people to maintain the contracts. It's equally hard to get people to come into the market. So lots of things that we're doing to try and support that, but recognising the dynamics that we've got there. So the whole point of this is that we need to address some of those general dental issues, but also to address some of the challenges within oral health as well, which would take some of the pressure off. This slide is fairly obvious to all of us, and there's been lots of work, some that we've received feedback from public patients, from MPs, from councillors, but some we've actually gone out with the help of Health Watch and other organisations to deliberately elicit some of the views and the comments. So not surprisingly, we know that people are extremely frustrated by not being able to get access to routine care, equally frustrated by not getting access to urgent care. One of the challenges that we've got, which isn't unique to dentistry, but it's a bigger challenge, is actually in terms of people accessing the services, being able to point them in the right direction. And we've had some issues nationally with a website that actually indicates out of date which services are provided in which areas. So there's lots of work that we need to do on that. Interestingly, despite all the struggles and challenges, when people actually get through to the dentist and NHS dentists, they do rate them higher than they do nationally. So there's that interesting imbalance of once you get into the service, it's good. It's just getting people into the service that is the challenge. So what we're trying to do is to actually rebalance the system. So if you think on the left-hand side of the pyramid, there almost shows a hierarchy of needs, with urgent access right at the top and the routine access for things like scale and polishing, regular checkups at the bottom of it. And so far, it's been tipped very much to the balance of the regular dental access. Now that's important. It's important for health reasons, it's important for health improvement reasons and maintenance of health. But the challenge that we've got, and we know we've got from what the public and patients have told us, is access to more urgent services. So that's been the focus of the dentistry part of this, but clearly we need to also address the oral health side as well as part of this piece of work. This is very much an emergent strategy. I think I promised a little while ago to bring something to board that would pick up all of the wider things that we're doing for various reasons, not least some of the shifting sands. We haven't brought this as quickly as we'd like to, but this is an attempt to parcel it all together and show that this is what we're doing. And therefore, when we look at the strategy, there's a range of things where we have actually done things, but also some commitments to we will do more, which is either doing things further or doing more work to enhance the work that we've got. It's all encapsulated on our plan on a page. So we've got our vision there, which is to reduce health inequalities, prevent dental disease, but also improve access to high quality dental service. So across the whole pathway, if you like. And there are 4 priorities and 4 principles there that we're busy working on. Increasing preventative oral health interventions, And a lot of that space is filled by working with local authority colleagues. And indeed, all of the local authorities have oral health strategies that we're busy working on now, and actually bringing them together to share some of the ideas that they've got, to learn from each other and to learn from some of the data. And at the end of last year, we put some sums of money into some of the local authorities to support and supplement some national monies that were coming to look at things like fluoride varnishing, assessment of children, and supervised toothbrushing. Next on the right of that is increasing access to urgent dental care, and at our last board meeting we accepted a paper where we're looking at putting in terms of a range of providers across the North East and North Cumbria up to 30 surgeries to provide access to urgent care, and we're making some really good progress on that. At the moment we've got 12 that have been established. We've got 3 that should come online in August and another 4 that come online in September, and more work to do with others. Some of this has been quite simple, a quick flip of the contract. Some of it's a bit more involved because of the complexities of the national contract and national requirements. We're also wanting to make sure we improve access to routine dental care, so a range of things that are included in the plan to support dentists, to support the public so they can get access to dentists in the right place at the right time. And one of the most important elements of this is the box on the far right as we look at it, which is improving the workforce with recruitment and retention. There's a national scheme, a Golden Hello, Golden Handshake, that was brought out by the last government. We've actually sat back and we haven't got into that because we didn't want to look at some of the perverse incentives that does. So we've actually gone to reward and recognise and incentivise people to stay within the NHS, irrespective of whether they're a newcomer into the system or not. We'll then review how that's gone, and then we'll see if we do then go into the Golden Handshake. But what we didn't want to do was to cheese off a whole load of practitioners who have been around the system for a while, and we want to recognise their input, and that has actually been really well received by dental practitioners. So linked to the plan on a page, we've got a range of timelines this year and for next year, and this probably exemplifies the fact that as we get into this, there's some of the things that we've already put into place, there's some other things that we'll be putting into place as we move forward, working with a range of partners. So we've got a timeline for things for this year, but then also into next year and beyond, to make sure that we have a focus on this, and the detail behind that will be a developed plan that's got some more grittiness to the timelines and the milestones that are in there. One of the key things, and it's a facet of all the things we talk about, is improving communications with the public and patients, and a lot of work will be going into this, particularly in terms of giving advice and support to people in terms of where to go, how to address some of the issues that you've got, and to be a bit more proactive than we've been so far. But all of this is predicated upon engagement with stakeholders and lots of work that's been picking up messages from people and almost sense checking where the messages that we're putting out to the public. There's a lot of work that's gone in this, and even the strategy, I've been through some of the slides in abbreviated version, but some of the strategy is quite detailed, it's quite involved. There's an immense amount of work that's gone with a range of stakeholders to who I'm really grateful for their input into this. I'm particularly grateful to colleagues within the ICB, the dentistry team who've worked on some of the dental side of this, and Anya Paradis, who's actually pulled this strategy together, but has had the audacity to be on leave this week, so she couldn't actually come and present this to take the credit for it. But a whole range of things, and going forward we need to make sure that we've got that approach with a range of partners and a range of stakeholders to ensure that we collectively deliver what we're required to deliver for the benefit of our local people. So that's a quick rattle through the strategy as it stands, the work that's ongoing. There is clearly more work to be done. One of the biggest challenges that the team have got from a dentistry perspective is the dynamics of this are quite fluid in terms of we have people who are still trying to hand contracts back. We work very, very hard with those providers to do as much as we can to mitigate the risk of that, but that just adds to the dynamics of, as we put things in place, some of the things disappear from it. I've got a sense of optimism about this, but there's an awful lot more work to be done. And the key bit is bringing patients and the public with us to understand that there is a fundamental shift of the work that we've done in the past to how dentistry is provided, and that wider oral health, because a lot of this is about making sure that particularly children, young people, but equally older people have access to advice and support to make sure they maintain good oral health, which will then reduce the need for some of the pressures that we've got on the service. So happy to stop there, Chair, but happy to take any comments or queries.
Thank you, David. Any questions or comments? David.
Just a quick one. Just thank you again for the work that's been done in this space. I think it's really fabulous given the challenge we've got in dental care. I just got a quick question, if that's okay. And you know the government manifesto target of 700,000 additional urgent care appointments. In the report it says our target is just over 57,000. My first question is that our target, or that's been given to us, or our estimate of what we think we can do? My second question is, we're aiming to do 28 to 30 UDACs, which will offer 14 30-minute appointments, which is a massive increase in capacity and very welcome. By my math, we'd be over 70,000 if we get to 28 times that rate, times 14, times 30, times 200 days a year. So I think we might be getting to the space of 70,000. And I just think that might be something to really celebrate. If we as a region are able to do 10% of a national benchmark, and I just thought, if we do get there, I think that certainly might want to think about how do we celebrate that achievement, assuming we get there. So two questions really.
Yeah, so the first point, David, yes, this was a target that was given to us by NHS England. It was divided out across all of the ICB, so our target's 57,599. So that's the challenge that we've got. You're absolutely right. You could argue we're putting more capacity in to deal with some of this, and if all of those UDACs come to fruition, we will well surpass that 58,000. The issue we've got is the way that the data is collected. Some of the current providers, or the previous providers, the dental practitioners, have provided some urgent care that is being picked up. So we're in that trying to balance things off a little bit, so we'll lose some of the dental contracts, but the UDAC should more than surpass the need. And we've deliberately done that because actually we've based the need not on that target, but the intelligence we've had from the likes of 111, where people have accessed services urgently.
Sam.
Thank you very much, Dave, to you and your team in particular for the really sterling work that they've done here, and also to all the dentists, our NHS dentists out there who continue to do NHS dentistry work and keep that flame burning. I can't help but think, though, this is like swimming against a tsunami, and I wonder at some point for us as a board whether we have a different conversation about dentistry in terms of what really does the future look like, given we know the challenges we are facing in terms of getting that NHS capacity. And then my only other question is probably for Dave and Levi around to what extent do we think we can build dentistry into neighbourhood health? I think it would be really amazing, wouldn't it, if we had some dentistry chairs in some of these neighbourhood health centres and we could join up the sort of dentistry with the wider aspects of health.
Just to assure you on that point, we've been very clear that pods, so the wider pharmacy, optometry and dentistry, need to be round the table in these local conversations. I must admit, I think it's been a little bit of an afterthought for some, so we're trying to reinforce that, yeah.
Sarah.
Thank you, Chair. Thank you, Dave, for a really comprehensive presentation. I'm just reflecting back to when we were looking at the capacity and the delivery of appointments last year, and we had a DNA rate of over 10% at one point, I think. My brain might be fooling me there. It might have been higher. I was just wondering what the capacity utilisation was at the current time, and whether we had full utilisation.
Yeah, it was probably slightly higher than 10%, the do not attend rate. One of the interesting things, one of the useful things about the UDAC arrangement is that because people almost have a contract with them, in terms of if it's me, I make contact through 111, there's a psychological contract there with I will turn up. The DNA rate has reduced significantly. What we are finding, though, is that because they do a whole course of treatment linked to the urgent care, there are some people who are coming getting the first part of it, but they're not returning for the second part. So we're doing some work around that. Sam, your point about the neighbourhood teams is really helpful, because actually if we look at one of the first centres we put in the UDAC centres at Firthmere and Darlington, it is indeed in a community centre. It's not in a dental surgery, it's in a, not standalone, it's mixed with a whole load of other things in Darlington, and that is a really good model that fits with integration going forward. The bit on dentistry and how we think about it, we've deliberately positioned this in terms of oral health for that reason, because there is a need to rethink this. And as I said, I'm optimistic that we'll make some progress on this, but actually, even if some of the national bits and pieces are added and brought up to speed, there's always going to be a risk that this is not going to be good enough and we'll not do what we need to do. So we will need to assess this. And that's one of the reasons we've only put a 2-year time scale on this, because actually we need to review. And if we continue to bang our heads against the wall and not making progress, then we need to change course. And that will be a useful board discussion in future. Thank you.
David, if I was to go out and about in the ICS, where would I be able to drink a glass of fluoridated water?
At the moment, in only some parts of naturally fluoridated parts of the system.
Am I going to be able to go and drink a glass in every local authority then?
Well, that's a moot question. One of the things that is linked to this strategy, and we've just touched on it as part of the strategy, is there's a huge impact that can be made from some of the public health interventions. Fluoridated water is one of the key ones. It's very much been agreed now across the North East that we'll have fluoridated water. Northumbria water are well geared up to actually deliver some of that. I think it's just about it actually being implemented. So that's a very waffly way of saying I don't know the exact time scale, Chair, but as soon as possible from everybody's point of view, because again, it'll take some of the pressure off dental services and, more importantly, make people have better oral health.
Thank you. Lisa, is that an old flag? Yeah. Okay, well, thank you again, and it's lovely to see all the progress that's been made in a difficult... The final substantive item, well, in fact, the only item, I think, is the procurement strategy. It's item 19.
Yep, thank you, Chair. Me again, and I'd like to welcome to the board meeting Julie Parkinson, who's our strategic head of procurement. Julie and her team are part of the team that have moved across to the ICB from Next. They provided support to us previously. One of the good things, apart from the knowledge and expertise that it brings to us as an organisation, is they can focus solely on North East and North Cumbria, which has been a challenge in the past when Julie and the team have been working for Next. Why have a procurement strategy? We've talked a lot this afternoon and this morning about being a strategic commissioner. One of the key parts of being a strategic commissioner is the ability to actually, I think the terminology in the current literature is to pay for services, but actually to procure, to buy services. And that's really, really important. So Julie and the team now, the focus on North East, North Cumbria, have developed this strategy which outlines a number of things. It goes into some detail about the technicalities of this, so the various legislation, the public service regulations and the Procurement Act regulations, some of which is about healthcare services, which is most of what we procure, some of which is about goods and services, which we do less of, but obviously partners and provider trusts do an awful lot of procuring things from there. So the strategy looks, in essence, at how we can use procurement to support the overall strategy of the ICB. Which is a really important thing, because we're not doing this just for the sake of it. We're doing it to make sure we actually deliver our overall strategy. And it's put in a number of objectives on page 7 of the report, or page 559 of the pack. It outlines the 7 key objectives that we'll be getting into, all of which are there to support progress with delivering the strategy. So I probably wasn't going to say much more about it. Other than it's there, it's been through executive. I think we've supported executive. We're really looking forward to Julie and the team playing some of this out over the next few months. They're playing a key part. One of the papers we took in the earlier session this morning in private was very much the work supported by Julie and the team for procurement of a service. So there'll be lots more of that to happen. So happy to take any questions or comments, and to be fair, Chair, Julie's probably happy to take any really technical questions that I'll not be able to manage.
Any questions or comments? No? Okay. Well, Claire, is there? Thank you very much.
If it would help the board, what we can do, Chair, is we can have a future session as part of a workshop where the team can actually go through some of the detail of the multiple changes that are coming along in terms of procurement, but just to help keep us right and understand our obligations as commissioners.
Yeah, and so we're being asked to approve this. Everybody happy to do that? Thank you. Claire, we had questions from the public earlier. Are there any more that you got up your sleeve?
Yes, there is one question, and it links to the procurement strategy for David. This question is from a company called Uniphar Commercial, and it is: what savings have the ICB and trusts identified using the NHS supply chain, and what actions have the ICB taken to ensure the NHS supply chain is the preferred procurement method to ensure best value spend and recurrent in-year savings?
Thank you, Claire. I'll probably take that in reverse order. As part of our arrangements and contracts that we have, the majority of the bigger contracts we have are part of the NHS standard contract. So contracts with particularly Foundation Trust, but other providers, an increasing number of providers, have that contract. And within that is the requirement to use the NHS purchasing arrangements. What we don't have outside of that contract is because a lot of our providers are GPs, where we have national contracts that aren't the standard contract. There's an understanding, but not a hardwired agreement, they should actually therefore use the procurement frameworks. So that's something we'll have a look at. In terms of savings, there is a group working across North East North Cumberland as part of our efficiency work that's looking at procurement. And while we haven't got the details of that, as that work progresses, we'll be able to feed back in terms of the efficiencies and savings being made. But a lot of that work's about standardisation and using frameworks to speed the process but to make some efficiencies.
David Chubb.
Yeah, I can just add to that, David and Chair. So as Dave says, there is a work stream. There is an ICS work stream on procurement. It's led by Dan Shelby, who's the procurement lead in Newcastle Hospitals. It reports into the System Recovery Board. And it has been given funding to invest in a tool that allows the trust to identify the best opportunities for them to maximise their, if you like, their non-staff spend budget. We have been encouraging, shall we say, to go further faster in terms of ensuring that both as an organisation system, they're maximising all those opportunities. That might require some additional investment in terms of procurement teams to get there. But Dan Shelby is currently working a proposal to come back to the ICS in terms of how they can do that. So they've got all the tools in place, and we are encouraging them to go further because we know, every pound you save, if you like, on non-staff, you can invest in staffing. But certainly the methodologies have been talked about earlier. If they're the best, they're the ones that trust will take.
Okay, thank you. No other comments then? You've got the date of the next meeting, and just to thank you all, it's been a very, very long day, so thank you for your patience and attention. I think the memorable phrase of the day for me was David Stout when he was describing there was no need for recommendations anymore, but that if the management got it wrong, you would have auditors wailing. I'm always to imagine the 12 days of Christmas we could add, 12 auditors wailing and a partridge in a pear tree. It appeals to me, the idea of auditors wailing, and I hope you will say to the audit community that we would like more wailing from them. That would be great. Thank you. No weeping, but lots of wailing. Okay, well, thank you. We're offline now, I think.